Good evening, everyone. Respected President, Urological Society of India, Professor Anand Kumar, Chairman, Indian School of Urology, Professor Rajiv Sood, Co-Chairman, Indian School of Urology, Dr. Arun Chawla, Past President of Urological Society, Professor J.N. Kulkarni, teachers, senior teachers, respected faculties for today's program, members and trainees from Urological Society of India, and members from SAARC countries. Today, in the month of this prostate cancer awareness, we are having another program on prostate cancer. This is A to Z on metastatic prostate cancer. Today, this program is moderated by Dr. S.K. Raghunath. He had laid down an in-depth program that is A to Z on metastatic prostate cancer. And this program will be very beneficial to all the trainees as well as the practicing urologists. With these few words, I welcome all of you for today's webinar. Now, I request the President, Urological Society of India, Professor Anand Kumar, to say a few words. Over to you, sir.
Good evening, friends, all the faculty, all the senior members, friends and colleagues. Today this webinar is one of the most important webinar is metastatic carcinoma prostate because it is the commonest presentation in across the country, and tier 2 and tier 3 city probably more than 50-60% patients present with metastatic cancer prostate, and in the tier 1 cities probably it is around 30% patient is still present with the metastatic cancer prostate. And even in my lifetime, there is a lot of changes and lot of development and lot of research and lot of new discovery has come. I remember when we passed it at that time, the only thing we had was the three things: acid phosphatase, by which we used to diagnose, and X-ray skeletal survey, which used to see sclerotic lesion, and patient used to present any advanced disease, and archectomy was the only treatment available. And slowly, when we finished our surgery training, we are in urology, then we heard about LHRH agonist, and then we heard a lot of things about PSA, and the PSA I remember 4,000, and then things have started changing in Western countries. Now they say metastatic cancer in very few patients, and but that was because of the screening, which has now not recommended by the countries. But even if the PSA has a significant role in decreasing the metastatic disease, and nowadays PSA screening is done in most of the places in two ways: either those patients who come for the health checkup or those who come with the lower latex symptoms, and we do pick up early cancer or early localized cancer. And so metastatic cancer is going down, but since it is one of the most common presentations, so I must say for most of the urologists and all of the urologists, this is one of the most important subject, how to manage, because now the patient is in this stage, he cannot be cured, but he can be palliated. And there is not one drug, there is a plenty of drugs. Now there is immunotherapy, chemotherapy, and there are so many agents which has evolved, and there is so many trials, and some of them are confusing because all the drugs are used in different ways in all the conditions, and there are so many trials, sometimes you get confused which trial means what. But things are evolving, and I am very sure this Raghunath has done a tremendous job, Raghunath and TP, and involved a lot of faculty members, and every aspect has been covered, and it will definitely help our members to understand what they can do. And if they do not have facility, at least they know what is possible, where they can refer the patient, and how can we palliate and improve the quality of life, and might even prolong their life for few months to few years. So with this, I would like to wish you all a very good health and pray for your good health of your family member and loved one. Stay safe. Don't take it lightly. Don't lower your guard. because now the pandemic is peaking, and I think in next month it will peak. So probably be careful and stay safe. Wish you all very good health. With that, I welcome you all for this very important webinar for all the urologists, whether he's practicing oncology or not, but he is going to see this patient and he must know how to take care of them. Thank you very much, and back to Rajiv TP.
Thank you, sir, for your enlightening words. Now I would request Professor Rajiv Sood, Chairman ISU, to say a few words. Over to you, sir.
Thank you, Dr. Rajiv. President USI, Dr. Anant Kumar, all the eminent faculty. Today I'm seeing so many, 45 of us are faculty, or maybe a big tumor board is here. And they are all interested in this special month of prostate awareness program. And today is the third week observance for the prostate cancer is going on. Dr. Raghunath has chalked down a very important program, and I'll only mention that the latest data, which has come in June 2020, it has shown that prostate cancer has entered into the 10 top cancers of India. It was not in 10 top cancers, and in the males, it is the third commonest cancer, while 2 decades back it was at 6th, 7th place, and in rural India it was not at all amongst male in first 10 cancer that was in from Barchi. So this is the growth. It is only second to lung, which is now 3-4 years back it was increasing by the rate of 140%, and today it is more than 210%. The growth is there, and annual incidence which has been registered is 5 to 9 per lakh population, while in the US it is 110 to 180. But to our surprise today, as we are concentrating on metastatic cancer, in spite of such a large gap between US and India, in absolute numbers, we are equal to US in metastatic cancer in numbers. And this is quite surprising. And this increased the burden, the financial burden on India. And that makes this webinar, which is A to Z in metastatic cancer prostate, very important. And we are all now exposed, whether we were interested in earlier, there was a time when many people, after seeing CA prostate, if they can do orchidectomy, they were doing, otherwise they were referring to medical oncologists. But now, A to Z of not only prostate cancer, which is the metastatic prostate cancer, we are studying today and interacting on that topic today. A to Z of the management, right from the suspicion, prevention, suspicion, diagnosis, and treatment to metastatic prostate management, even neoadjuvant treatments, or maybe the diagnostics, the molecular and other aspects which we are going to deliberate, and also the terminal, up to terminal care urologist is involved. So this is very, very important webinar, and I wish all of us a great success for this webinar on CA prostate metastatic. This is the 5th dedicated day in the month of prostate awareness, which is going for CA prostate, and many more days are going to be organized by different faculty and groups to observe this day. We should all now, from Urological Society of India, ask to include the men's health and the CA prostate, focusing into the new initiative national program, and that will be very important if we are going to get through ICMR the organized registry data management, which USI has taken important initiatives, and this will consolidate our knowledge. And when we talk about urologists, we talk about prostate, it is not only BPH, it is CA prostate which is attracting more attention because it is a real public health problem. And the survival after diagnosis, 5-year survival after diagnosis is 64% in India today. And this can improve with the more experience sharing, and also interactions. All the best to all the people, all the delegates, also and residents who are watching and who has got connected on the internet, and all the faculty, because each one of us is going to be benefited today. Thank you very much.
Thank you, sir, for your kind words. Now I would request Dr. S.K. Raghunath, convener of today's program, to take over the proceedings. Over to you, Raghunath.
Thank you, Dr. Raju. Very good evening, all the office bearers of USI, ISU, my dear teachers, seniors and friends. A lot of developments have taken place in the management of metastatic prostate cancer, starting from new hormonal agents, secondary hormonal agents, PARP inhibitors and theranostics. The palliative care is generally not addressed very well in India, and it is neglected in our practice too. To address all these issues, we have prepared a fantastic scientific program for 4 hours. We have very eminent and experienced faculty. I welcome you all to this webinar. I sincerely request all the moderators and speakers to stick to your time. For paucity of time, we will not be introducing all our faculty, as we all know them. With this brief note, we would like to start the first session. We have 6 sessions. The first session is genetics and imaging of metastatic prostate cancer. I welcome moderators Dr. Ashwin and Dr. Indranil, and I welcome experts Dr. Hemant Tongaonkar and Dr. R.B. Sarnis, sir. So over to you, Dr. Ashwin and Indranil.
Good evening, everyone. Without wasting much of time to set the ball rolling, it's a pleasure to introduce first speaker, Dr. Mithua Bo. She is the Director of Department of Molecular Oncology and Clinical Genomics at HCG Hospital, Bangalore. The title goes as What Urologists Should Know About the Genetic Evaluation of Metastatic Prostate Cancer. Over to you, madam. Madam?
Please unmute, ma'am.
You have to unmute yourself. You have to unmute yourself, madam.
You have to unmute.
We can't hear you. Please unmute. Dr. Mithua, please unmute and start your presentation. Dr. Mithua, can you hear us?
Yes, sir. I'm unmuted now. Can you hear me?
Yeah, please go ahead.
Please go ahead.
Yeah. So, so the answer of this question, which has been asked today, what we should know about the genetic evaluation, we all know that cancer is genetic, and prostate cancer is not an exception. Now, there have been a lot of genetic alterations in cancer. These alterations could be somatic, could be hereditary. About 90 to 95% of cancers are somatic, whereas about 5 to 10% of cancers are hereditary. So now the recent treatment perspective has become more of genome specific rather than organ specific. We are no longer treating the patient as per the NCCN guideline or as per the histology, but we are treating the patient as per the cellular and genetic makeup of the patient. We also know that early stage prostate cancer is treatable and long-term survival is high if the disease is localized. However, and unfortunately, 30 to 40% of prostate cancer metastasize and are incurable in spite of multimodal therapy. So why is it so? The reason is because the disease is very heterogeneous. There are a lot of genetic and cellular heterogeneity, as I explained, and this can be seen in this slide that there are different, it's not a single disease, it's some plethora of or a multi-step process where plethora of genetic alterations or genetic pathways are responsible for the cancer progression from a simple, normal epithelia to pin to a localized disease to an advanced disease. There are several cellular pathways like DNA hypermethylation, androgen receptor pathway, as Dr. Raghunath mentioned, DNA repair pathway, PIK3, RAS pathway, and there are different pathways and different genetic alterations which cause the disease. And there are many landmark papers which have shown that 80% of metastatic prostate cancer harbor clinically actionable molecular alterations. About 20% has DNA repair pathway alterations, and 8% are germline findings. Now, the question comes, what is the utility of genetic testing? Why should we know the genetic makeup of the patient? The first help or utility is it helps us to understand the right drug the first time. That is, when I say of therapy, is FDA-approved therapy, in-trial drugs, and off-label drugs. Now, any personalized medicine or individualized medicine needs evidence. So I'm showing you a brief case study. This is a patient, 59-year-old, who has undergone multiple chemotherapy with Zoladex, capecitabine, docetaxel, androgen synthesis inhibitor like abiraterone and enzalutamide, but did not respond, came up with severe metastasis. When genetic testing was done, he was found to have 3 mutations. One mutation was in the gene, AR receptor gene, which reduces the response to the hormones. And this is very common in hormone-dependent prostate cancer, which first respond but then stops responding due to development of de novo or acquired mutations or resistance. There were other 2 gene mutations called CDKN2A or PTEN, which gave us an option to start some new drugs like palbociclib, ribociclib, mTOR inhibitors, or PARP inhibitors. The patient was started with combination of palbociclib and everolimus, and he's having a stable disease and on follow-up. The second utility of genetic test is to understand the risk predisposition. As I said, 5 to 10% of cancer is hereditary, and prostate cancer is not an exception. Look at this case. This is a 58-year-old adenocarcinoma prostate, undergone prostatectomy, no hormonal, no chemotherapy, but there was recurrence within a year. So when the patient came to us, we did both somatic and germline mutation for him, and we found a pathogenic BRCA mutation. The family had a history of cancer. Both his mother and sister had breast cancer. So this patient was found to have BRCA2, which not only told us that this family has a risk predisposition factor, it also gave us an option of using PARP inhibitors as monotherapy or in combination therapy for this patient. Now, as we all know, immunotherapy is a buzzword, and one of our senior members said that. And we also know immunotherapy is quite expensive. These are the therapies which boost our patients' immune cells to fight with the cancer cells. Now, immunotherapies are expensive, and we can't give them blindly. So we need the molecular genetic signatures to find out the right candidate for immunotherapy. There are 2 immunotherapy already approved for prostate cancer, which is one is vaccine and other is pembrolizumab, for which doing the molecular signature like microsatellite instability or a tumor mutation burden or PD-L1 by different technologies like ISU, PCR, or NGS is very important to find out the right patient for the right drug for the best clinical outcome. With this, I would like to conclude my talk here and reiterate or emphasize that genetic testing should be made mandatory for prostate cancer treatment and management, not only to understand the right therapy which needs to be given, but also to understand what are the therapies which should not be given, because giving unsuitable therapy which does not go with the genetic makeup will be a waste of time as well as money. And also to understand the prognosis of the tumor, whether it is a slow growing or a fast growing, aggressive, how will be the response to chemotherapy, radiation, etc. Now, as per NCCN guideline, as you all know, BRCA testing has been made mandatory for all women with all patients with metastatic PCA, regardless of family history. So you did not take family history. It has to be made mandatory for all metastatic PCA. The reasons are 2, not only to find out the risk predisposition, but as you all know, the PROfound trial in 2019 has, where the PARP inhibitors like olaparib has been granted breakthrough therapy designation by FDA. It is not only now BRCA. I must say we should go beyond BRCA. There are a lot of homologous repair recombinant genes like—
I have 1 minute to go.
which should be tested because olaparib or PARP inhibitors have been recommended for this. So to conclude my talk, genetic testing, somatic and germline is essential for efficient treatment and management of prostate cancer. Thank you so much.
Thank you, madam, for the excellent overview. We have 30 seconds. If you can answer a quick question about, there is a question in the chat box. Should genetic testing be done in all or only when we have treated with 2 or 3 lines of treatment in a metastatic setting? What is your take on this, ma'am?
So as per NCCN, it should be done with metastatic PCA, definitely. But if you ask me as a scientist, as a researcher, I would say it should be done early on because you know the genetic makeup, you can plan your treatment strategy accordingly.
Yeah. Thank you, ma'am. Over to you, Indranil, to introduce for the second speaker.
Thank you, Dr. Ashwin. Let me introduce Dr. Kallur. He is a Director of Nuclear Medicine and Imaging in SCG Cancer, Bangalore. He will be talking on what is the best imaging to evaluate metastatic prostate cancer. Over to you, Dr. Kallur.
Hi, good evening. My talk has been limited only to the metastatic setup, so that makes it more easier for us. And in India, 85% of cases will present in either stage 3 or stage 4. So you are already aware of a scan called PSMA, which has become quite common. Earlier, when I started introducing about 10 years ago, I was having a tough time to convince the people to use this scan. Today, it is a buzzword, and all of you are using it in day-to-day practice. So I'll not go into detail about these things.
Can you do it full screen, sir? The slideshow.
No, can you hear me?
Sir, can you make the slideshow mode? The slide
screen.
Full screen.
Okay, no?
No, sir. Okay, yeah, so we can see it.
Can see it now?
Yes, sir.
Yes. So the choice of radio tracers are FDG, FACBC, and PSMA. FDG we were using earlier to know the aggressiveness of the disease, but it was not at all good because it accumulates only in aggressive tumors, and CA prostate is a slow-growing tumor, and we were missing it. Then came FACBC. It is still used in Europe and USA because they have a problem with PSMA-based ligands and license problems. In most countries in Europe and in India, we are using PSMA. And what PSMA stands for, it is a transmembrane glycoprotein. It is highly expressed, about 500 to 1,000-fold more in cancer cells. And we use an antagonist for this PSMA, and that is why we are picking up with high sensitivity and specificity. That is the funda of using a PSMA scan. Earlier, we were using a choline PET scan. You can see here, we are seeing same patient. We are seeing only one pelvic node, and same patient. The next day we have done, and you can see more number of lymph nodes. That's why it has become quite popular, and it is the standard of care now. So what is the salient feature of the PSMA scan? When PSA is less than 2.2, in say, for example, a patient who has undergone a prostatectomy, at least 84% of them will show some abnormality. And once the PSA is more than 2.2, 100% of those cases show more abnormalities. So what is the use in the metastatic setup? And it has a high positive predictive value and a moderate sensitivity to pick up a lymph node metastasis. And still it has a good sensitivity of various papers say 33 to 100% specificity up to 100%. And in detecting biochemical recurrence after salvage lymph node dissection, the positive predictive value is very good, is anywhere between 70 to 100%. And detecting detecting the biochemical recurrence based on PSA cutoff values are like this: less than 0.2, it can be almost up to 50%. Anywhere between 0.2 to 0.5 is up to 72%, and less than 0.5 to 0.1, it can be up to 87%. Today, the technology is advanced. We were missing small lymph nodes. That is why the sensitivity specificity was low, and we were not able to avoid RPLND. And today, with the advent of a digital PET-CT, we can. This is what is the new technology now, where you can see the smallest of the lymph node. This is just 1 or 2 millimeter lymph node, and you can nicely see those lymph nodes. And prostatectomy on follow-up shows the skeletal metastasis. PSA probably you would have never done when a PSA patient in a follow-up case comes less than 0.1 or 2. Here is a case, the sensitivity is so good that we are able to show the metastasis even when the PSA is 0.07. And bone scan, it is almost redundant now. We have stopped doing in our center, and I am sure in most of the centers elsewhere. The reason is we are missing the lesions in this. You can see in the CT part, looks almost normal here, but the PET shows a good uptake here. And marrow lesions were being missed in either a bone scan or F18 bone scan, and we are able to see the marrow disease very nicely in the PSMA scan. So a literature review of 12 studies, about 1,346 patients. There are two here, either in the diagnosis, how it will affect, and the treatment aspect, how it will affect. It will upstage the disease in 32 to 67%. Demonstration of positive lesions, even in the patients when PSA is less than 0.5 is very good. It can identify recurrence at the earliest stage so that you can again intervene either surgically or by radiotherapy or other means. And during treatment, how it is going to affect. It will affect the management to the tune of almost now 30 to 76%. This is huge. Resulted in avoidance of systemic therapy in some cases, and resulted in PET-directed local therapy also. And suppose this is an example to show that when you are doing a radical prostatectomy or RPLND, please consider this, because this is a case where PSA never came down, and we are able to demonstrate why it never came down. So a patient undergoing radical surgery, PSMA scan is mandatory now. And how it can help identify oligometastasis. And this is an example to show that this scan can avoid certain therapies or postpone certain therapies. For example, hormones here. We started in 2010, that time we were doing choline scan. And in 2013,
That's 1 minute, sir.
Yeah, 13, we saw one small lymph node, and we were able to show lymph nodes did not increase, other metastases did not increase. And in 2014, one more lymph node came, and patient was refusing hormone therapy. And for 4 years down the line, he started hormone therapy based on our advice. So this is how the PSMA scan will also tell how to manage the metastatic disease. And it will also help in the case like this, how the chemotherapies are helping the patients. So what are the guidelines that say it is about 2B evidence as per EU, ISTRO, and ESUR guidelines? And NCCN guideline also recommends that it is good nowadays. And it acknowledges that the earlier detection of recurrence is at the lower PSA levels. And there is a newer concept called as imaging tumor stroma. This may be a new buzzword in all the cancer detection in the future. Because in any cancer, the stroma makes up 85 to 90% of the tumor bulk. And we have just started in our center what is called as a FAPI scan. Still, many of you may not be knowing about it. This is a case where FDG scan, PSMA scan, and the last one is a FAPI. Sorry. So the summary is 85% of cases in India diagnosed stage 3 or 4. So it is safe to recommend PSMA scan straight away. And it will avoid many unnecessary procedures. You are able to diagnose, and you know the tumor burden, and is able to pick up at a very low level PSA values also. And it will help you in the management of the patients.
Thank you, Dr. Kallur, for your excellent presentation. Let me introduce the expert panelists, Dr. Tangwakar and Dr. Savnis. Over to you, sir. There are a few questions in the chat box. We will address that also. Over to you, Dr. Savnis and Dr. Tangwakar.
Hello, good evening. Well, I think it's time that urologists start thinking in terms of genetics in prostate cancer, not only for defining the genetic predisposition for prostate cancer or other cancers, but also from the point of view of personalized management of metastatic prostate cancer by guiding important treatment decisions. We know that about 8 to 10% of prostate cancer patients have these germline mutations, and this is important for family genetic counseling. But what's even more important, that up to 30% of metastatic CRPC patients harbor deleterious alterations in the DNA damage repair genes. And these alterations actually confer a sensitivity to PARP inhibitors like olaparib. And if a patient of mCRPC has these alterations, rather than giving them conventional treatment to which they may not respond well, it is better to give these patients PARP inhibitors, which have shown to improve the radiologic progression-free survival. Similarly, in those patients who have MSI positive or those who have the mismatch repair gene deficiency, they can be treated with something like PD-L1 inhibitors like pembrolizumab, and you can get very good responses in these patients. Similarly, you can choose treatment based on the splice variant of AR7. You can do that in the circulating tumor cells. And if that is positive, you should not use enzalutamide or abiraterone, but you can go on to taxane straight away. So basically, that is why, because of these things, today NCCN guidelines recommend that in all patients of nodal metastasis and distant metastasis, you should be doing genetic, but even more importantly, somatic tumor mutations, especially for BRCA1, 2, and for ATM genes. Thank you.
Good. Thank you, Tongaonkar. I think Dr. Kallur also made a very nice presentation. And he has made an important point that although there is no mention in the guideline that PSMA PET scan should be included as a preoperative workup, I think that is very important. And all of us are actually doing that in our own setup, although it may not have come in the guideline. But we know that in our country, the disease is completely different. And we do pick up sometimes the metastasis where we don't expect it. There are two quick questions I want to ask you. Is that the one thing is that when you are actually imaging in a metastatic workup, and if the PSMA is very low, and there is a other varied variant like on histology, small cell carcinoma, intraductal carcinoma, then which is the variety where you have to do follow-up? What sort of a scan you are going to do? That is one. And secondly, Dr. Kochikar has asked that you showed a very nice picture that even 2 mm lymph node can be detected, which is positive. Now, do you have any study where if these lymph nodes are dissected and removed, are they collaborating with the final histology, positive histology, and what is the pickup rate in that? So these two questions, can you have a quick comment?
Okay. First one was I just
for the low PSA.
Low PSA. Okay. No, when we are doing the PSMA scan and a high index of suspicion, you have a diagnosed a metastatic prostate, but we don't see that nice uptake in the PSMA at all. So immediately we know that something is different. The histopathology may be different or its behavior may be different. We immediately call the patient for FDG, and usually sometimes we see that disparity. And usually it may be transformation of a neuroendocrine variety. So in those patients, we raise the possibility that there may be neuroendocrine differentiation and tell the urologist that we would like to do a Dotanot scan, which goes and accumulates in the neuroendocrine varieties. So we are able to tell even by the imaging probably what may be the behavior of the tumor, number one. Number two is about the lymph node. Yeah. The lymph nodes per se, our sensitivity specificity was low because initially when we started offering this scan and you went ahead and did RPLND, you are picking up in fact more number of lymph nodes which were positive than they were seen on in our PET scan. Small lymph nodes or microscopic disease, obviously we will not see it. Today the technology has improved, and with the digital PET CT we are able to see about the 2 mm lymph node. This is what we are seeing. This is still very expensive equipment. Not many centers may be having this facility. But to be frank with you, what is the pickup rate and what will be the positivity? I am very sorry to tell that I don't have any
I think
thing to say. But whatever we say, it is better to do a biopsy. But when you are doing isolated lymph node here and there, one retroperitoneal lymph node, it becomes very difficult to convince the patients to undergo surgery or to do a biopsy and do it.
Thank you. I think these are modalities which are evolving, and I'm sure with the way in which the imaging is getting advanced, the situation will come where everything will be imaged properly with a very, very high specificity and sensitivity. So once again, thank you very much for a very nicely covering that topic. Over to you, Dr. Raghu.
Thank you, sir. Thank you, my dear moderators and experts. We will move on to the second session, that is oligometastatic CA prostate. I invite my moderators, Dr. Anup Kumar and Dr. Rakesh Sharma, and the experts, Dr. Sudhir Raval and Dr. TBU Raja. Over to you, Dr. Anup.
Thank you, Dr. Raghu. I would like to thank USI, Dr. Rajiv, TP sir, and Dr. Raghu for giving us this opportunity. I welcome my co-moderator, Dr. Rakesh, and we are going to have 3 presentations during this session, and the end our experts will have their comments. So I will invite my co-moderator. He wants to say a few words, and then we can invite our speaker.
Good evening, everyone. At the outset, I would like to thank USI and Dr. Raghunath for giving this opportunity. Yes, sir. So we have this session on oligometastatic prostate cancer. So the first speaker for the program is Dr. Himanshu Pandey, who is an associate professor in the Department of Urology at AIIMS Jodhpur, and he's going to speak on the topic of what is oligometastatic disease and low volume and low risk disease. It's this is a separate entity. So, Dr. Himanshu Pandey, you can start your presentation.
So, very good evening to all of you. Is the slide visible?
Yeah, please go ahead. We can see your slide.
Okay. So, the topic allotted to me is the oligometastatic disease in CA prostate, low volume and low risk, whether they are same or separate entities. So why there is a need why there is so much concern of oligometastatic, or why there is so much interest of oligometastatic disease in CA prostate? Because of that improved imaging, having PET-CT and FDG, and because of having increased availability of local regional treatments like stereotactic radiotherapy, minimal invasive surgeries, and availability of more efficacious systemic treatments in CA prostate, even in the metastatic settings, targeted therapy for
the slides are not readable, sir.
Hello?
Yes, sir. The slides are not readable, sir. Can you stop sharing and reshare it? And please untick for the video, basically.
Okay. Just hold on. Stop video and...
No, stop video also, sir.
Okay, I have stopped my video.
Yeah, so, reshare the screen and untick the optimize for video option over there.
Okay. I have unticked it.
Yes, now share the screen.
Is it okay?
Yes, sir.
Is it okay?
Yeah, you can
yes,
proceed, Dr. Manshu. Now you can proceed.
Okay. So, so there is so much interest in oligometastatic disease because of all these points I have mentioned, along with the multidisciplinary approach of a treatment. So it has been said that the treatment of oligometastasis in prostate cancer can offer better local control and can reduce the systemic metastatic disease, and also can delay the need of the androgen deprivation and its associated systemic side effects. So by definition, if we want to define the oligometastatic disease, so frankly speaking, there is no generalized consensus on the definition. In various studies, it has been defined right from the 1 or less than 1 metastasis to 5 or fewer metastatic sites, and it actually depends upon the imaging studies which have been used in various studies. Like we can see on this table, or in this table, that different studies or different authors, they have used bone scan, FDG PET scan, choline PET scan, or other imaging modalities to define the metastasis, and they have found right from the 1 to 5 or less than 5 metastasis to be defined as the oligometastasis. So coming on to the high versus the low volume disease, the few of the trial like Charter trial, Stampede and JETUBE trial, they have defined the high volume disease having 4 or more than 4 bone metastasis with 1 or more outside the vertebral bodies and pelvis, and with or without visceral metastasis or the extranodal. So Glass et al. They defined the extensive disease or the high volume disease based on the appendicular skeletal metastasis and or visceral metastasis. So basically, we follow the Charter and the Stampede trial for defining the high volume and the low volume diseases. So what is the theory behind the oligometastasis? Basically, this term was coined in even way back in 1995 by the Hellman, and who described that this oligometastasis is an intermediate state that exists between the local and the widespread disease. And the another theory is the clonal theory, in which it is said that the fate of the metastatic disease or the fate of the metastatic clones, it is decided or defined itself in the primary tumor. Having good primary tumor condition, they develop into the oligometastatic disease, and tumors having the poor primary tumor condition, they develop into the polymetastatic disease. So this slide shows the hypothesis 1, that the fate of the tumor metastasis is defined within the primary tumor itself. The tumor is having bad prognostic features, it develops into the polyclonal metastasis, and if it is having favorable features, it develops into the oligometastatic state. And later on, the oligometastasis can develop into the polymetastatic disease depending upon the favorable or the unfavorable features later on expressed into the oligometastatic state. So recently there has been interest into the microRNA therapy, which says that the microRNA 200 family, especially the 200C, it has a special role, and microRNA 200C enhancement in the oligometastatic cell line, it induces the polymetastatic progression, and it has been linked to the polymetastatic progression. So we can say if the prostate cancer itself or the oligometastatic sites or the metastatic cells, they are expressing a high expression of the microRNA 200 family or the microRNA 14q32. So they can develop into the polymetastatic disease even directly or even from the oligometastatic disease. So this is the microRNA theory. So this slide shows how the microRNA 200C is linked to the various pathways which can lead to the development of the polyclonal or the polymetastatic state. So what are the different types of the oligometastatic prostate cancer? Roughly divided into the de novo or the synchronous metastasis. Second is the oligorecurrent or the metachronous disease, or third one is the oligoprogressive castration resistant. So if we define the synchronous metastasis, it is the metastasis or the recurrent lesion which are diagnosed or present in the active primary lesion. And metastatic oligometastatic disease is said when the primary disease has been cured, and after a period of initial disease-free interval, there is a presentation of new or the increased oligometastasis. So this is called the metastachronous oligometastatic disease. When the majority of the metastatic disease is controlled by systemic treatment. Yes, sir.
Dr. Himanshu, 1 minute
yes,
left.
Sir. Yes, sir. A few resistant clones are there which progress despite the systemic treatment because they are resistant. So if we say, it has been said that the prostate cancer amongst all the cancer in the body have some favorable primary. So coming on to the risk factors, what are the risk factors in the oligometastatic disease? It has been seen and said in the various short case series that increased number of the metastatic lesions in visceral metastasis, they have poor outcomes, and the tumors having the microRNA 200 family overexpression, they have poor outcomes in comparison to the oligometastasis having not having the expression of these genes. And the MSI independent or microsatellite instability independent immune activation have most favorable survival. As it has been said that the main prognostic factor in the oligometastatic prostate cancer is the status of the primary lesion. So active primary lesion, as in the case of synchronous oligometastatic disease, is said to be having worse prognosis than the controlled primary lesion. So crux or the points of concern is that there are few or limited data with a limited retrospective series, no randomized control trial, and varying definition of regarding the oligometastatic disease and the what.
Thank you. Thank you, Dr. Himanshu.
Yeah, thank you. So now we move to the next presentation, that is the debate, surgery versus radiotherapy, and we invite Dr. Gagan Gautam to speak in favor of surgery for oligometastatic disease. Over to Dr. Gagan.
Thank you so much, Anup. And Dr. Raghu, can you see my screen, please?
Yeah, please just make it full screen and you can continue.
Right. So I'm going to speak on surgery for oligometastatic disease and why that's really the in thing now and we should really start considering it. But first of all, I want to tell you that Vedang is a very, very good friend of mine. And I think it's my duty to make him happy first and foremost. So in the next couple of slides, I'm going to present you some data, which I'm sure he's going to talk about and going to make him very happy. So this is the Stampede arm, which shows that if you give local radiation therapy to the primary, in patients with oligometastatic disease, you're going to have an improvement in overall survival, whereas the same is not true for the all comers when it comes to metastatic disease, only for low volume oligometastatic disease. So now it's in the guidelines. And in fact, even in the EAU guidelines, it says that giving prostate radiotherapy in those patients who've got oligometastatic disease should be recommended and should be considered, whereas the same may not apply for high volume disease. So Vedang would think that the debate is over, slam dunk, he's won, radiation therapy is the only way to go forward. But I would request him to hold on a minute, and I would request all of you to consider that how does radiation therapy really work? Now, Vedang may give you all this mumbo jumbo about these radicals and going left, right, center, immunogenicity. I don't know what he's going to talk about, but I think the basic fact is that whatever mechanisms you choose, what's happening is basically the radiation therapy is killing the cancer and shrinking the tumors, period. And if that is the case, there is absolutely no way why surgery should be any different or in any way. He comes from Mumbai, so I'm telling you potato and potato or batata is actually the same thing. So surgery should also be the same thing as far as radiation goes. And it is not a new concept. We have talked about it. We have written about it in 2014. This was an article which was published in Indian Journal of Urology. I wrote it basically as a summary to a trial which came around in that time, 2014, based on a SEER Medicare study, which said that those patients who have metastatic disease but receive some form of local therapy, in this particular case, radical prostatectomy mainly, have a better overall survival as compared to patients who just undergo a normal standard androgen deprivation therapy kind of a treatment. And in fact, the authors even identified certain factors in which this local therapy is likely to be better. But however, even in those patients who were older, patients who had a high grade disease, patients where PSA was more than 20, doing some kind of local therapy did benefit. Of course, this is retrospective, this is biased, but we do have some evidence that some form of local therapy is working. So why not surgery? And now there are also some other studies, case control studies, retrospective studies, which do show that local therapy in the form of surgery for oligometastatic prostate cancer may actually be beneficial in terms of these patients' overall survival and progression-free survival. This is the trombone study, which has completed accrual and is currently about to be published. We don't know the data yet, but this is the first randomized study which will be published, which will look at surgery as a in a cytoreductive setting for oligometastatic disease. There are not one, not two, not three, but 9 prospective randomized trials which are looking at local therapy and surgery for patients with oligometastatic disease. This is one of the most famous ones, which is currently undergoing accrual. This is the SWOG 1802 study, which is randomizing patients of metastatic disease into either surgery for the primary, radiation for the primary, or standard care alone. And we will have this data in future to show. Next year, probably Stampede will start enrolling in its M arm, which is basically a treatment of the local disease with surgery as radical prostatectomy, whereas it already has had data from the H arm, which is basically the radiation therapy to the primary. So it's very clear by all this that in all the design of these trials, surgery is being considered as an option and as equivalent to radiation therapy and is being explored further for local treatment. But there is another advantage to doing surgery as compared to radiation therapy. We all know about the side effects of radiation therapy, and they cannot be swept under the carpet. And if you have a prostate like this, you can be pretty sure that if you are going to give radiation therapy to this prostate, you are in trouble. We have all seen people with local recurrence after radiation therapy. We have seen people where a large prostate, when you irradiate it in a locally advanced setting, can result in a high incidence of bladder outlet obstruction, repeated TUR channelings. If you leave the prostate there, you're going to end up in situations where later on you may want to put a PCN. All those things also cause a lot of morbidity in the terminal stages of a patient's life. When you look at all this combined morbidity of repeated procedures and repeated morbidities of the same, I think removing the prostate when you can is definitely a worthwhile option in oligometastatic disease, especially when you're expecting the person to have a relatively longer life with new modalities of treatment coming in every day. So surgery in this situation not only will take care of the primary in terms of and give the advantage what radiation is giving as per the Stampede trial, but also decrease the morbidity of local recurrence, eliminate the need for secondary procedures, and at the same time, using modern robotic techniques, the continence recovery and complication rates are not any different if you do a surgery in an oligometastatic disease as compared to non-metastatic patients. And let's not forget, there are some complications which are unique to radiation therapy. Nobody mentions when a patient goes in for radiation therapy to the prostate, nobody mentions that you can have an increased incidence of prostate cancer, bladder cancer. This is something that is conveniently swept under the carpet and hardly anybody is counseled about it. Is there a problem with radiation therapy? Absolutely no problem. But you can get bladder cancer as a result of treatment for prostate cancer as well.
Dr. Gagan, you need to wind up, please.
My last slide.
Yeah, thank you.
So therefore, who is the ideal patient for surgery? Well, I think in most patients who are younger age, who have a good performance status, who have a good life expectancy, and who have got a oligometastatic disease, especially in the presence of large prostate and significant lower urinary tract symptoms, which results in a patient becoming more prone to the complications of radiation therapy. Definitely, I think surgery for oligometastatic disease is something that should definitely be considered and may be the go-to thing in the future in this situation. Thank you very much.
So thank you, Dr. Gagan. You have very well proven your point for surgery. Now I invite the second person for the debate, Dr. Vedang Murthy. He'll be speaking for radiation in oligometastasis. Dr. Vedang, you can start.
Vedang has to unmute. Unmute, Vedang.
Right. Thank you, Gagan. Now it's time to get real from fantasy. And I call this a no debate. Gagan has probably done half my job by showing the evidence. So I call this a no debate because on one hand, we have evidence, logic, rationale, even guidelines. And on the other hand, we have a surgeon peering deep into his robot, trying to find what is written on the left. And if you're wondering who this is, our friend who's trying very hard, who's going a lot going for him in this profession, but not in this debate. And before I jump into my defense of the topic, I came across a very interesting article with a very interesting title called For Oligometastatic, Fighting a Challenge or Tilting at Windmills. And if you're wondering what this is, it's from a Spanish novel. It's called Attacking Imaginary Enemies. And from the looks of it, only one of us is tilting at the windmills, because Gagan has also shown we are in the guidelines. If you don't like NCCN, there is EAU. Many of you follow EAU, so it's all there. And how have these guidelines come? Again, Stampede has shown overall survival in benefit in exactly the patient set that we are talking. This is over 2,000 patients randomized and a large difference in overall survival in a pre-specified analysis. And the toxicity and the burnt charred chicken that he showed doesn't really match up. You can see here 4 to 5% of the patients only got any serious toxicity. So that's something to think about. The other trial that he did not mention, I'll just, this is for education purposes, a smaller trial called HORAD, randomized patients to ADT or ADT plus RT, and improved outcomes, as you can see here, in patients who had less number of metastases. Now, what is the evidence that is going for surgery? We are waiting for trials, yes, but the current evidence is only from the SEER database that Gagan showed, retrospective small studies, and as he correctly said, these are biased. The best results that I could find is from this 80-patient study, which showed an improvement in loco-regional complication rates. Fair enough. So that is the benefit that is published with surgery as of today. And a beautiful article, beautiful review article, I think everybody should read this, year or two back. Patients should be counseled about the potential significant reduction of local complications, which I have shown, and the fact that complication rates are relatively higher when you're doing a cytoreductive prostatectomy, as there is some evidence of that. retrospective data, and patients should undergo surgery today only within ongoing randomized trials, which unfortunately we do not have. So rather than showing you more data, let me give you my thoughts as to what surgery will have to do to prove itself. The first part is the easy part. And this is already in the trombone and in the SWOG trial. ADT versus surgery plus ADT, you'll have to show superiority in a trial, and this is likely to happen soon. And there is no doubt local therapy will benefit. There is no doubt surgery could be one of them. But then it will come down to this, because the standard of care would now be ADT and systemic therapy plus RT versus the same plus surgery. And this is not likely to happen probably ever, because you'll have to show non-inferiority or superiority. And again, the high-risk debate of surgery versus radiotherapy will be reborn in the oligometastatic state in a different avatar. And Gagan and I will be debating about this till we retire. Before I finish, I'd like to show you a word of caution. Many of you being in the uro-oncology field may not be aware of this. This is a randomized trial in breast cancer, in which patients were randomized this was done in Tata Hospital, loco-regional treatment, that is surgery, which was added to systemic therapy, which was there in both arms. Exactly the same concept. It started in breast cancer. Surprisingly, yes, there was benefit in loco-regional progression-free survival, but the distant PFS worsened significantly. This was published 2-3 years back. You can see here. So be careful while jumping onto the band for these kind of treatments before there is evidence in randomized trials. These things can happen in real life. And finally, I'd like to leave you with a frank conversation that would happen in a urology clinic. A patient with oligometastatic cancer is there. We say that, like, look, unfortunately, you have incurable metastatic disease. You need lifelong systemic therapy, which can be costly and it can be toxic. Yes, that is something that you have to take. We also believe now that there is the treatment to the prostate can benefit you. It could be radiotherapy or surgery. We have two options. Radiotherapy to the prostate has clearly shown that it can prolong your life, but we want to do a major surgery to remove your prostate, and it has such and such a cost and such a side effects. I would just wonder what the patient is going to do. So I will leave you with that thought, and I rest my case. Thank you so much.
Thank you, Dr. Vedang. Excellent presentation. Now it's time for Dr. Gagan for the rebuttal. 2 minutes for Dr. Gagan.
So thank you so much, Vedang. That's really an awesome talk. I think with regards to your last slide, I would like to say the conversation will go something like this, that local therapy in the form of radiation therapy has been shown to improve survival. There is no reason why surgery should be any inferior to radiation therapy, because basically they are acting on the same principles. Right now, we don't have evidence. Level 1, yes, but there are a number of ongoing trials which should come out in the next few months, years, whatever. However, we do believe that because a large component of your morbidity in the future is likely to be because of local growth of the prostate, we do believe that removing the prostate right now is likely to benefit you in the long term by decreasing the chances of local recurrence and morbidity, because a lot of these tumors can come back after radiation and cause a lot of problem in your later years requiring multiple interventions. That's where I will stop. But on a more compromising note, I would like to say that I think we have moved from a point where we used to say radiation only for high-risk prostate cancer to the point where we said, okay, surgery you can consider, to the point that we say now that, okay, you can probably combine both and do a multimodality treatment. I think as the treatment becomes better and better for the metastatic component of the disease, and as we are able to push further and further the disease away and extend the lifespan because of multiple medications, local morbidity and local symptoms will become more and more important. And we may even reach a point where we would give systemic therapy, we would do surgery, and then we would consolidate it with so-called, adjuvant radiation therapy for oligometastatic disease for the primary. So that day, I think we will still be working and not retired by the time that day happens. Over to you, Vedant.
Yeah, thank you, Gagan. So I just have 2 points, one which I agree with you and one which I don't. Not from this, what you just commented, from your talk. So I would definitely recommend a patient the kind of picture that you showed, uh, uh, the type of prostate with the locally advanced disease. I would definitely not recommend radiotherapy. And if you can operate that patient with a lot of lower urinary tract symptoms, very large prostate, I think that would be a reasonable approach to go ahead. So that is one thing that I agree with you. The other thing you talked about is bladder cancers. Now, believe me, it is not as clear as you think that all patients after radiotherapy or a significant number of patients after modern radiotherapy have bladder cancer. Number one, much more than what they would have after surgery. Number one. Number two, the median survival of these patients is only going to be 3 to 4 years. And really don't worry about the bladder cancer in these particular patients. Use that argument in the high-risk prostate cancer. I'll be happier. So I'll stop there.
Okay. So I thank both the speakers, and we move on to the next speaker, who is Dr. Srinivas Chilkuri. He is going to speak on metastasis-directed therapy. This is a last talk for the session. I invite Dr. Srinivas. You can proceed, Dr. Srinivas.
Can you hear me now?
Yeah, we can hear you.
Yeah, my task is cut out after an excellent debate, whether to do surgery or to do radiation to the local prostate. Now I'll be talking about metastasis-directed therapy in the same setting. Obviously, before the oligometastatic paradigm, systemic therapy was reserved for disease control and improvement of survival. Local therapy was used for palliation. But in as late as 88, there was a small study by Soloway who showed that patients with less than 6 bone metastases had 2-year overall survival of 94%. So that actually triggered the paradigm of oligometastatic disease in prostate cancer, as was shown by this beautiful article by Hellman in 1995. So the rationale for metastasis-directed therapy would be to eradicate the oligometastatic sites, and hopefully that will stop the dissemination of disease further from mets, because metastasis itself could be an important source of further spread. And there could be... Hello?
Please continue. Please continue.
Yeah, please continue.
And hopefully by stopping the further dissemination, we could improve the progression-free and overall survival. And there is also a small benefit which we could probably gain, is that we could postpone the systemic therapy and consequently its associated toxicities and the financial burden and the package associated with it, and hopefully achieve a stable quality of life. And that could be achieved either through metastatectomy or radiation SBRT, depending on the location. If you're talking about a solitary brain metastasis, probably would be a metastatectomy would be a good choice. Surgery, if it is a lung in a central location, again metastatectomy would be. But if it is a peripheral lung or a bone met, I think radiation would be an excellent option. So the best evidence so far as metastasis-directed therapy goes is the SABRE COMET. This is a very smartly done phase 2 randomized trial of about 120 patients. As I mentioned, it is not restricted to prostate only, but it is basically they have done a 1:2 randomization between the standard of care versus standard of care and SBRT to all known disease sites. So it is entirely metastasis-directed therapy. So as I mentioned before, prostate constituted one of the major components of the study, but there were other cancer patients as well. But with a shorter follow-up of about 2.5 years, it showed a significant improvement in median overall survival from 28 to 41 months. And this was a significant study probably in the last decade as far as radiation goes, and oligometastatic paradigm is almost proven with this study. But they also showed that with a longer follow-up, this overall survival benefit continued, and it is as high as 25% benefit. In fact, one of the critique of the study is because they have included prostate cancer patients, the benefit is so much. Nevertheless, it proves the point that there is a significant benefit in overall survival as shown in other studies as well. So coming to synchronous metastasis, I think they have already discussed, but the point is there is a significant benefit, overall survival benefit of about 7% if you combine HORAD and STAMPEDE. But there are other trials which are addressing, as mentioned by Dr. Gagan and Dr. Vedang. But the point comes to oligo-recurrent, which is actually the metastasis-directed therapy, where you see that there are oligo-recurrent disease, which are typically metachronous, and whether a metastasis-directed therapy would really benefit. And this study beautifully also, again, ORIOL is a phase 2 randomized study, smaller study, 54, 2:1 randomization. Primary outcome was progression-free survival. And it clearly showed that patients who received SABR had a better overall outcome compared to patients who received the standard of care. And not only that, the study had a beautiful secondary endpoints. What the investigators did, they did a PSMA PET at the beginning, at the baseline, and after 180 days. But the result of PSMA PET was blinded to half of the patients. And of course, PSMA PET picked up a little more lesions compared to the conventional imaging of bone scan. And those who had a discordant results, that means PSMA PET showing additional findings.
Excuse me, Dr. Srinivas, you have completed 4 minutes. Kindly wind up next 1 minute.
I have 7 minutes, I think.
Okay.
So there was a group of patients where the results were discordant, a group of patients who were concordant. Those who had discordant had a significantly inferior overall survival, stating the fact that treatment with SABR for oligometastatic prostate cancer improved outcomes, and it also showed when you see disease, there is a benefit treating it. Phase 2, another study which is basically the primary endpoint was whether to see ADT could be delayed, and this study also showed that median ADT-free survival was significantly better in patients who received metastasis-directed therapy compared to observation. And in fact, it also showed that biochemical recurrence-free survival is also significantly improved. In patients who have oligoprogressive disease, which is castrate-resistant prostate cancer, where the progression-directed therapy, that means wherever the progression is seen on a PSMA PET, and basic rationale being patients, we can keep patients responsive to ongoing systemic therapy and hopefully delay the onset of next-line therapy. And there are prospective trials ongoing in other primaries as well. And there are 2 large cohorts of patients which have proven that it is possible. So to conclude, local therapy show promising outcomes in multiple prospective phase 2 studies. CyberComet has shown it could lead to improvement in overall survival. Both radiation surgery are being evaluated in phase 3 setting. And of course, the modality will depend on the location, the patient and physician preferences. Thank you.
Thank you, Dr. Srinivas. Now we invite our expert, Dr. Sudhir Rawal, to please give an expert comment. Dr. Sudhir Rawal, sir.
Thank you, Anup. Can you hear me?
Yes, sir. Please go ahead.
Yeah. This is a great session which we had, and I will just comment on few things. Otherwise, everything has been discussed. The first talk by Himanshu Pandey, when you say this oligometastatic disease, is actually many authors they describe as the tip of the iceberg only. There is no iceberg below; it's just tip of the iceberg. So that is why these patients behave differently rather than if you have the florid metastasis. So they should be treated aggressively either by radiotherapy or by surgery. Coming to the debate, which was an interesting debate anyway, I am certain I'm not here favoring Gagan or not. I'm not against Vedang. Both of them are very good speaker. Only thing which I can tell you that local treatment is definitely required because this is the site which keeps on sending the metastasis to the elsewhere in the body, which has been shown with the dense, deep dense sequencing. But the trial which Gagan mentioned about the randomized control trial, which is going on in MD Anderson, I have some insight into this. And the initial data in the trial has shown that no one is winner. The surgery and the radiotherapy, they are equally effective in the outcome of the survival. But definitely in selective patients, patient surgery is scores over because of the local control. Now the last talk was MDT, and as you know that it is logical to treat the metastatic disease. Otherwise, there is no fun in just leaving these patients and let the metastasis keep on growing. And this probably will be proven in future that this does help especially with the new radiotherapy technique coming, SBRT and all. And then there's a subset of the patient where again surgery can help as the metachronous oligorecurrent disease, where if the nodal disease is there, one can remove. There are many reports in the literature when you can remove these lymph nodes, and including ours, and we have also done this surgery, when you can remove these nodes and then you can see follow the patient with PSA only if you have the longer disease survival and you have oligorecurrent disease. Thank you.
Thank you, sir. Dr. Yugaraja, sir, now your comments.
Yeah, thank you. I think that was a wonderful overall view. I think Dr. Raval has already spoken about everything. So to just add a point, I think as surgeons, we wanted to give a cue to the patient. I think indications for surgery or radiation or the local treatment is going towards advanced diseases. Now we can check ourselves. We have moved to a locally advanced to the metastatic oligometastasis. Now it was surprising to see there are 3 randomized trials going on for a palliative or a cytoreductive prostatectomy being done for a metastatic prostate cancer. I think the future is bright for surgeons where we can have more and more cases. I think there is evidence and we're going to create evidence. As surgeons, we usually a little setback in creating evidence compared to radiation oncologists. I think we have some evidence to do this type of treatment. So that's the only one point. Otherwise, everything is covered. Thank you so much.
Thank you, Dr. Anup and Dr. Rakesh for conducting this session. And I also thank expert commenters, that Dr. Sudhir Raval and Dr. Yugaraja. We'll move on to the third session, that is hormone-sensitive prostate cancer and CRPC. The moderators for this session is Dr. Raghavan and Dr. Ganesh Bakshi, and experts Dr. Makrand Kochikar and Dr. Hemang Bakshi. Over to you, Dr. Raghavan and Ganesh Bakshi. We are behind the schedule by 5 minutes. Thank you.
Thank you, Raghunath and the USI. We will start straight away with the plan. We are seeing Hemant sir's screen right now. Sir, the first speaker in this session will be Anant Sivaraman, who is going to talk on the advantages of orchidectomy. So can I invite Anant to come along, please? Anant?
Yeah.
Yeah, please, Anant. Go on.
Can you share my see my screen?
Yes, Anant, please.
Thank you, USI, for this opportunity. My talk today is going to be in support of orchidectomy for cancer prostate. So the gold standard has always been the gold standard. It will be the gold standard in future as well. It is surgical castration. Let me substantiate this. So Charles Huggins discovered in 1941, and he's been awarded the Nobel Prize for that. So it can't be that bad. Technically simple, cost-effective, outpatient procedure done under local anesthesia. Castrate levels within 3.5 hours. Surgical complications are unheard of for orchidectomy. Emotional components can be overcome by subcapsular orchidectomy or prosthesis, and impending spinal cord compression is an exceptionally good way to treat by doing orchidectomy. So what is the goal in ADT? We all know ADT is the cornerstone for treatment of CA prostate in metastatic setting. What is the goal? It is testosterone suppression. So what is the best form of testosterone suppression? And when you compare orchidectomy to LHRH antagonist, previously we were comparing it to agonists, but even when you compare it to antagonists, testosterone levels are far lower, 0.0178 versus 0.297. It's definitely significant. So orchidectomy fares better than antagonists when you look at testosterone levels. What about agonists? Orchidectomy does not have microsurges. Orchidectomy does not have compliance issues, especially in these corona times. I had plenty of patients call me and say, can we postpone the LHRH injections and so on. So we don't have cold chain problems with orchidectomy, because sometimes these agonists need cold chain and you're not sure whether it's been well maintained. So again, definite benefit for orchidectomy when you compare all these things. So is there any survival advantage to orchidectomy?
Shut up, debate. Nice.
I did a review. And when I found this gem, they substratified patients in good group and poor risk patients, and orchidectomy versus medical castration. It didn't make a difference in good risk patients, but when you looked at the poor risk patients, there was a definite survival advantage as well as progression-free survival advantage when you looked at orchidectomy versus medical castration. And what about quality of life issues? Again, a paper from Egypt looked at global health status, functional scales, as well as symptom scales. Far better when you consider orchidectomy versus medical castration. So does orchidectomy have more adverse effects? This is something that people talk about. Paper from Harvard came out in 2020 in JAMA Oncology. When you looked at fractures, peripheral arterial disease, cardiac-related complications, statistically significant difference where orchidectomy was better compared to medical castration. The difference was trending towards orchidectomy in diabetes mellitus as well as cognitive disorders as well. So definite evidence here, but these are all retrospective data. What about the Indian context? You know, in India, the cancers are increasing significantly year on year. In fact, prostate cancers had a 221% increase. Can all prostate cancer patients avert the latest castration drugs available? Is it an economic burden? That's something that we need to look at, right? If we talk about cost, surgical castration, we all know, is phenomenally cheaper when you compare to medical castration. In the Indian scenario, 80% of patients choose surgical castration primarily because of cost. It's free in government hospitals, cheap in private hospitals, and the patient has to procure LHRH antagonists and agonists, which a lot of insurance companies don't cover. If you look at this paper, again, the paper from Harvard, they've done an orchidectomy, 1 year cost was $9,000, which is about 7 lakhs in Indian rupees. Unless you use gold-plated prosthesis, nobody in India can do a orchidectomy for $9,000. So again, that's different data, different set of people, different medical processes going on there. So we cannot just blindly follow that. In the Indian context, there are certain things that we need to address. People talk about it being irreversible, but then again, continuous ADT is definitely better than intermittent ADT. The importance of shared decision making, the patients need to be told that there are other good options like ADT, like castration when you compare it with agonists and antagonists. And a lot of talk going on about FSH suppression with antagonists. An orchidectomy causes 300 times FSH increase and so on. But there is no robust data that proves that FSH is the cause of arterial plaque rupture and so on. So again, that's something that we need to bear in mind.
Anant, 1 minute to go. Thanks.
So to conclude, for India, and probably for the rest of the world, surgical castration is still the gold standard and will be in the future. It is safe, simple, cost-effective, and ideal surgery to do. Considering the cost of subsequent treatment in cancer prostate, especially when you go to HRPC, it is logical to counsel patients to undergo orchidectomy. So do yourself a favor, do your patients a favor, and probably the country by reducing the economic burden. I think orchidectomy is the way to go when you treat prostate cancer. Thank you.
Awesome. Anant, so eloquently put, so eloquently put. There is nothing else I can say. We'll invite the next speaker, Ruchir. Anant, fantastic, beautiful. We'll invite the next speaker, Ruchir, to come and put the case for LHRH agonist now. Are you there online?
Good evening, everyone.
Thank you.
Let me share the screen.
I would request the next speaker to be having the screen share ready for the next talk as well. Thank you so much. 5 minutes, please.
So, thanks, Dr. Anant, for a fantastic talk regarding orchidectomy, no doubt. As a surgeon, knife is foremost. If we can do it without any complication, easily. But then, as medicine progresses, things change. Mentality change, the outlooks change. So, as we go into the timeline of ADT, things have progressed since the first case of prostate cancer was detected. The ADT was reported by Huggins and Hodges to all the fancy and costly drugs in 2020. So, LHRH agonists, as we all know, there are certain mechanism. That's a pharmacological target in which receptor and anti-pituitary acts.
and continuous serum levels of LHRH agonist ultimately stimulate the receptor. True that there is a transient surge of LH and testosterone, which is up to 10 times, and there is downregulation of receptors in 2 to 3 weeks, and subsequent suppression of testosterone production by T cells. And it has proven effective both in treating metastatic disease and giving survival advantage. The advantage over treatment, definitely no surgery. People are still skeptical about surgery, and the body image is there. As far as subcapsular orchidectomy is considered, then the training in India is still not many people are doing it. And if we leave any testicular tissue inside and attempting to do it in a subcapsular orchidectomy, we are not doing a service to the patient. So different LHRH agonist molecules which have developed over the years with different mechanisms in the intramuscular acetate, the subcutaneous ones, the triptorelin, goserelin, and hysterelin. The advantage of these over the newer fancy GnRH antagonists is the timings. We can formulate or we can give the patient a different time, be it 1 in 1 depot to 6 months or even 12 months depot. So that solves the problem of patient coming again and again to the clinic for the injection or procuring the injection. We go for one injection, and the convenience of the patient, we can go for the next injection from 6 months to 12 months. The ease is definitely, it improves the compliance of the patient. There is no local site reactions, unlike LHRH antagonists. There is definitely no surgical complication, how may lower the incidence may be. And the cardiovascular advantages, they may be overhyped. So when you compare the this antagonists with agonists, they definitely they are saying that cardiovascular related events are more in agonists. But as they say, data pulled from randomized phase 2 and phase 3 trials comparing the GnRH antagonist degarelix with GnRH agonists show that 40% reduction in risk of cardiac events of death with degarelix versus antagonist. But mainly it was seen in patients with pre-existing cardiovascular disease, not in all the patients. So in this beautiful chart by recently published, they have set certain contraindications for GnRH antagonists or agonists, which are mainly the risk for cardiovascular disease, and in the patients in whom there is a risk of spinal cord compression or risk of ureteric obstruction.
1 minute to go, Dr. Ruchir.
Yes, sir, sure. So another paper from Japan in a retrospective analysis of clinical efficiency utilizing hormone-releasing hormone antagonists as compared to agonists with combined androgen blockade in advanced prostate cancer. They found there is no significant difference in PSA-free survival between LHRH antagonists and agonists when used with combination androgen blockade therapy. And in the patients in whom we suspect that the disease load is high, there is a risk of spinal cord compression or this, we can safely start it with the combined androgen blockade, and we can safely tide over the initial LHRH surge. Thank you.
Thank you so much, Dr. Ruchir. Really appreciate that. Nice case put across for us, agonist. The only thing I noticed is that you made a list of things that are potential contraindication for agonist, which includes diabetes, hypertension. Almost every Indian is a hypertensive and a diabetic. So that will be something we need to think about. So we'll get the third speaker to defend the case for antagonist now. Ravi?
Thank you, Dr. Raghavan. And my worthy opponents have very clearly put a case for orchidectomy and agonist, and I appreciate that. But then I'm the youngest in the team of the LHRH usage. I have nothing to disclose. We will discuss this among these points: suppression of testosterone, efficacy on disease outcomes, tolerability, and age and the cost. So clearly, suppression of testosterone, degarelix outperforms leuprolide, both in terms of early suppression and more efficient suppression, that the levels go less than 25 nanograms. And it also shows that it suppresses at all levels of testosterone irrespective of the values. And we have some data to say that even lower testosterone is high grade disease. So that's where degarelix scores over leuprolide. And there are no microsurges. Coming to efficacy of disease control, this is a randomized 5 compared to randomized trial systematic review. And the graph clearly shows that degarelix outperforms with respect to PSA progression-free survival in all patients and in patients with baseline PSA more than 20. And also it has shown some improvement in overall survival. More so, it has also showed that patients experience less, there's a less risk of experiencing musculoskeletal events and renal and urinary tract related adverse events. Now coming to the cost, I agree with Dr. Anand that in Indian setup, yes, orchiectomy is a preferred choice. But when we compare to agonists, there is a cost analysis which was published recently, and it shows that degarelix outperforms leuprolide with respect to cost, just because it decreases, it has less side effects with respect to disease. So degarelix or LHRH antagonist clearly outperforms in almost all parameters and probably comparable with orchiectomy except for the cost. And it doesn't have tumor flare, and it is cardiac safety, which we have yet to discuss. We all know, and Dr. Raghavan rightly said, that majority of the patients have cardiovascular risk factors. And in fact, this table clearly shows that agonists have higher chance more than orchiectomy with respect to sudden cardiac death. And this paper shows that antagonists almost halve the risk of cardiovascular events. And a recent randomized trial showed that the incidence of major adverse cardiac events is to the tune of 2.4% in antagonists versus 20% in agonists. And similarly for CV. And the pro-BNP levels were significantly low, which is a marker for cardiac failure in antagonist usage. Again, a recently submitted paper in AU 2020 where real-life data from UK shows that degarelix clearly outperforms leuprolide for any cardiovascular events. Italian real-world analysis again shows the same thing, that degarelix is better than leuprolide with respect to overall survival, even in patients who doesn't have previous cardiovascular disease or those who have cardiovascular. In both the situations, it is better. And it is because of the potential cause is because of blocking FSH, because we know, and it has been well studied, that FSH is responsible for development of a lot of metabolic syndrome. So that's where probably, if money is not an issue, then orchiectomy, it scores over orchiectomy. Now to further push the boundary, we have an oral medication, which is relugolix, an oral GnRH antagonist, which clearly takes away all that surgical problems, all that medication problem, because it's an oral medication, more acceptable. And it has shown that it is much more effective than leuprolide. It also causes very good testosterone recovery, and it decreases the MACE events by almost half. So dear friends, I don't want to say the results, but we have to wait for this pronounced trial till we actually conclude that degarelix is better than leuprolide. Thank you.
Excellent, Ravi. All three speakers put their cases very nicely. This is a very learned crowd. I don't think so we can have rebuttals here. Everybody knows all three options are on the table. And obviously, as Anand said, the most effective option for the common man to use on a day-to-day basis will still remain orchidectomy, but the other two are also equally efficacious options as well for us. And it is like a platter. People choose what is in the best interest of that patient in that circumstances. And the LHRH agonist and antagonist have the advantage that it is a reversible, especially when you're going to give as an adjuvant therapy for radiotherapy, or or where patient is having any form of adjuvant or a neoadjuvant therapy. These drugs come very handy. Versus orchidectomy is reserved as a permanent form of treatment. So with those thoughts, we will move, and we obviously have the experts to comment at the end of the session. Thank you all the three speakers. We really appreciate your time. We'll move to the next topic. Dr. Hemant sir is going to tell us about the side effects of ADT and the complications. Sir, please start.
Good evening. Androgen deprivation therapy is the most important palliative treatment for metastatic prostate cancer. But the problem with this is that it is associated with a lot of side effects, more so if the patient is old, has a lot of comorbidities, and the duration of treatment is very long. The most important of these are the metabolic syndrome like diabetes, insulin resistance, etc. Cardiovascular morbidity is extremely important, and it's unrelated to the duration of ADT. And you can see that the risk ratio for a fatal or non-fatal MI is almost about 1.57. So in patients who have prior cardiovascular problems, then there is a significant increase in cardiovascular morbidity in patients who receive ADT. Similarly, a lot of these patients have osteopenia or osteoporosis, sometimes non-metastatic bone fractures, and they need calcium and vitamin D supplementation. The real problem, especially in young patients, now I don't know how to define young, is cessation of sexual activity in almost all the patients who receive ADT. Neurological problems like cognitive decline is extremely important because these patients sometimes they seem lost to the world, and that's because of the ADT and not only because of their age. They also have other problems like hot flushes and gynecomastia, but those are not as troublesome as the other problems. Now, whenever we talk of androgen deprivation therapy for metastatic cancer, we know that metastatic prostate cancer is incurable. And despite ADT, all these patients are going to progress to a stage of castrate-resistant prostate cancer, which is a lethal stage. And within 2 to 3 years, it is going to progress to death. Since progression to castrate resistance is a major cause or major step, is there any way we can prolong the progression to castrate resistance? And with that in mind, the concept of intermittent androgen deprivation came into being. It was shown that replacing androgens before the disease progression itself prolongs emergence of androgen-resistant clones by restoring apoptosis potential and delays castrate-resistant cells in patients on ADT. Secondly, there was a clinically meaningful relief from side effects of ADT in the off-treatment period with improvement of quality of life. The testosterone recovery was good with better sexual function and a significant decrease in the treatment cost. So conceptually, intermittent androgen ablation is good, but is it substantiated by evidence? That's most important. Now, coming to the actual procedure, we know that we start with LHRH agonist or antagonist, give it for at least 7 to 8 months, not more than 9 months, because then the testosterone recovery can be compromised. And when the PSA comes to below 4 for metastatic disease and below 0.5 for those with biochemical failure, then this treatment is withdrawn and the patient is closely followed up. And when the PSA goes above 10 to 20, or when there is signs of clinical progression, or if the clinician feels that this patient is likely to have a problem, then ADT is restarted, which is again given for about 3 to 6 months. What is most important, that patient, to the compliant, well-informed patient is very, very important. Coming to the evidence, there are 8 phase 3 trials of continuous versus intermittent therapy, but 5 of these had mixed population of metastatic and non-metastatic patients, and there was lack of consistency in study designs, non-inferiority margins, off and on treatment criteria, etc., etc. So review of all available phase 3 trials highlighted the limitations of most of these trials and suggested a cautious interpretation of positive non-inferiority results, that even if both the approaches were shown to be non-inferior, the result should be taken with a pinch of salt, basically because of these lack of consistencies. What is most important for us to realize is no trial to date has shown improved survival with intermittent therapy. I'm just going to show you 2 trials which are very, very important. One is in metastatic prostate cancer, the SWOG 9346 trial. Out of 3,000 odd patients, 1535 were randomized to IID versus CAD. The follow-up of 9.8 years and mean endpoint of overall survival. This was a non-inferiority study with the upper boundary for hazard ratio of death is 1.2. Now, if you compare the 2 arms, there were 445 deaths in the continuous arm, 483 in the intermittent arm. The median survival was 5.8 versus 5.1 years in favor of continuous arm, which represented 10% increase in the relative risk of death with IID. Now, if you look at the hazard ratio for death, you look at the 90% confidence intervals, the 0.99 to 1.23. Now, 1.23, this upper limit of confidence interval was above the pre-specified limit of non-inferiority of 1.2. What was defined a priori as the limit of non-inferiority was crossed. And that's why it was not possible to conclude that IID was non-inferior to continuous treatment. And 20%, as much as 20% difference in the death rate would not be ruled out. Which
sir, one more minute, sir.
It translates into absolute survival difference of 1 year. Post hoc analysis showed an overall treatment was generally consistent across subgroups. What was even more important that the erectile function, mental health, etc. was better at 3 months, but not thereafter. There was no difference in grade 3, grade 4 adverse events, no difference in bone, sexual, endocrine, or cognitive side effects. In fact, the recent data showed that there is an increased risk of thrombotic events and cardiovascular, including fatal events in the intermittent arm. So it is conceptually good, but not substantiated by evidence. So it is not as innocuous as we thought earlier, and it is not recommended for metastatic disease. And the second one was in patients who had non-metastatic disease, those who were treated primarily with EBRT and on biochemical failure randomized to continuous versus intermittent arm. No difference in survival, non-inferiority is reached. But you can see that the follow-up was only 6.9 years. Now, these are patients with low disease volume, and these patients would require a much longer follow-up to observe the events, that's deaths from cancer. And even there was just 41% deaths due to cancer, but there was a trend towards more cancer-related deaths and lower survival in Gleason 8 to 10 in the IID arm. So, although there was non-inferiority, still there was a trend towards worse survival. So to conclude, where do we offer intermittent androgen therapy? It is very difficult to clearly segregate patients who would and would not benefit from intermittent therapy. In patients with metastatic disease, high Gleason score, high PSA, and high PSA doubling time, they would not benefit from intermittent therapy. In fact, there could be harm. So it must be used with caution. It may be offered after proper counseling to highly motivated asymptomatic N1 patients who have major response after induction period. While those patients who have a lesser disease burden, that means locally advanced non-metastatic disease, or those with only lymph node mets or biochemical relapse, IID would probably be non-inferior. So especially in older men with comorbidities, Gleason 7 or less, poor tolerance to ADT, and slow PSA rise, they would probably be treated with IID. So careful patient selection is the key, and we should have individualization of treatment. Thank you very much.
Sir, thank you so very much. I mean, this is probably the best summary that you can ever give. IID is to be taken with high caution, with careful patient selection, and it is not one size fits all. It is not a generic treatment. As you said in one of your slides, it's eloquent, it's nice, but not necessarily translates into real benefit. So as the standard treatment today stands as a continuous hormone treatment for metastatic disease. So thank you so much. We'll wait for the experts to pass their comments. We'll now invite Srivatsa to talk about the explosion of the new hormonal agents that have come to the market. Thanks, Sri. Can start straight away.
Good evening. Thanks, USI and conveners for the opportunity. So my assignment for today is to highlight about the drug per se of abiraterone and enzalutamide. So I will try to keep it crisp, and I have also tried to include a few slides for the postgraduates. So as we all know that this is the standard landscape of prostate cancer treatment that we have been seeing for a long time. The landscape as such has not changed. But when we have identified unique clinical situations, we find that there are several opportunities in which we can try to adopt new treatments and benefit the patients. So we'll talk briefly about abiraterone first and enzalutamide later on. We all know that abiraterone is a potent CYP17 inhibitor. It prevents the synthesis of process of cholesterol in the adrenal gland primarily by inhibiting the 17-alpha hydroxylase as well as the C1720 lyase. It's a very potent inhibitor. It almost blocks all pathways of the corticosteroid as well as the androgen mechanism. And what is more interesting to note is that while both surgical orchidectomy as well as the medical castration reduces the serum testosterone levels to as low as 20 or even below sometimes, abiraterone is noted to further reduce the testosterone levels to the range of 1 or 2 nanograms per deciliter. Abiraterone acts predominantly by blocking the CYP17 pathway not only in the adrenals primarily, it also blocks the androgens synthesis at the level of the testes and also blocks the autocrine androgen secretion within the prostate tumor cells. Coming to the pharmacokinetic properties, Following oral administration, abiraterone acetate is hydrolyzed to the active form of abiraterone, and it attains a maximum plasma concentration in about 2 hours after administration. While it's a very useful drug, it comes with a lot of side effect baggage, as we can see in the subsequent slides. And one of this is that whenever it's administered with food, the absorption varies drastically without a set pattern to as high as 5 to 7-fold with a low-fat diet to 10 to 17-fold with a high-fat meal. Therefore, it is recommended that abiraterone acetate should not be administered with food. It is mostly metabolized in the liver biotransformed in the liver into the active form. And the mean plasma terminal elimination half-life is about 12 hours. And abiraterone is predominantly excreted unchanged in the feces. It has to be very carefully or judiciously used in special population, especially those with hepatic impairment. Patients with child-poor criteria of class B, hepatic impairment, should have a dose reduction by 1/4 and should be administered only 250 milligrams and should be carefully monitored with the liver enzymes. And patients with severe hepatic impairment are absolutely contraindicated from receiving this drug. Because it's a potent CYP inhibitor, it's not unique or exclusively an inhibitor of CYP17. It also inhibits other CYPs like the CYP1A2, 2D6, 2C8, 2C9 and others. Therefore, a lot of drugs which are metabolized through the CYP pathway should be carefully administered when abiraterone is being given, especially the anticonvulsants like the carbamazepine and the phenobarbital, as well as the antitubercular drugs like rifampicin should be very carefully used while the patient is on abiraterone. Coming to the brief summary of abiraterone usage in prostate cancer, where all has it been used, I have divided the use case scenario into 3 groups. The first one is the metastatic treatment-naive prostate cancer. Abiraterone was originally found to be useful for CRPC post docetaxel, but I'll just go with the sequence of the disease flow. 2 trials very strongly suggested that abiraterone in the treatment-naive setting has got an excellent outcome with almost 17% disease-free survival advantage as well as 13% overall survival advantage. So both these trials independently showed that abiraterone acetate given along with the standard of care of androgen deprivation therapy for newly detected metastatic prostate cancer patients increases the overall survival, increases the radiographic progression-free survival, failure-free survival, and also reduces skeletal-related events or postpones the time to the first skeletal-related event. Coming to the role of abiraterone in post-docetaxel setting in the castration-resistant prostate cancer, this was the first trial that was evaluated, the COU-AA301, which utilized abiraterone and prednisolone versus placebo and prednisolone. Close to 1,200 patients. What they found out is that the hazard ratio for usage of hazard ratio with usage of abiraterone, both to time to PSA progression as well as radiographic progression, was very low. That is 0.58 and 0.67%, which were very statistically significant. So this trial concluded that all these parameters, that's the progression-free survival, the radiographic progression-free survival, PSA response rate, as well as the objective response rate. This is very, very interesting. Based on the RECIST criteria, DFS as well as the OS was better when abiraterone acetate was used in this setting. And this response was persistent with all subgroups of patients, which was regardless of age, metastatic burden, visceral metastasis, as well as the prior treatment burden. Coming to the role of abiraterone in a pre-docetaxel setting of castration resistance, the COU-AA302, again using abiraterone and prednisolone compared with placebo, showed that it improves. I thought I had 7 minutes.
Yeah, already 6 minutes.
Okay, radiographic progression-free survival and overall survival in all patients in the study, regardless of other parameters like pain, PSA, as well as the primary Gleason score. Where abiraterone is not indicated or preferred is in M0 CRPC as well as in visceral metastasis, especially the hepatic metastasis in particular. This is the standard prescription. I'll just skip that. The most common adverse events are asthenia, fatigue, decreased appetite, LFT derangements, fluid retention, and worsening of blood sugar controls because of usage of steroid. This is the follow-up protocol for adverse effects, 2 weekly LFT and electrolytes for 1 month, monthly for the next 2 months and 3 monthly thereafter. It's very important to monitor the BP, blood sugar levels, as well as CBC and RFT periodically. And coming to COVID-19 situation, we need to suspend abiraterone treatment because it prolongs the QT interval whenever patients are on HCQS therapy. I'll just skip this as well.
You have completed 7 minutes. Please conclude in 10 seconds.
Yeah, enzalutamide again works with, it's a multi-pronged approach for a mechanism of action, completely inhibits androgen binding, impairs nuclear translocation, as well as inhibits AR interaction with DNA. 4 major trials, enzalutamide has been approved in almost all settings, including the M0 CRPC. I'll just skip all this. Enzalutamide literally does not have major side effects, doesn't require the usage of steroids, and this is the standard prescription for enzalutamide. The most common side effects are asthenia, fatigue, anemia, arthralgia, and seizures, which were highlighted before, are actually very rare.
Thank you, Sri. We'll move on to the next. Dr. Raghu.
We have to move on to the Sri. Thank you so much. The explosion of the newer drugs has brought us to the new set of drugs, apalutamide and darolutamide. So we are requesting Dr. Rahul Yadav to talk about that. Sir, kindly stick to 7-minute time span, please. Thank you so much.
Good evening, everyone. Thank you for the opportunity. I'll be talking about apalutamide and darolutamide. Disclaimer, no potential conflict of interest. I have nothing to disclose. If we look at the discoveries, landmark discoveries in treatment of prostate cancer, almost 79 years of experience when and he bagged a Nobel Prize in 1966. And we are still evolving. This is a timeline for the development of hormonal therapeutics for prostate cancer. It's basically in 2012 to 2013 when abiraterone changed the way we used to label cancer as hormone resistant to castrate resistant prostate cancer. And in 2016, enzalutamide approved. Later on in 2017 and 2019, apalutamide and darolutamide approved for various stages, which I'll be discussing. If we come to mechanism of action, the drug, all the androgen receptor antagonists, they basically prevents DHT-AR binding, thereby blocks the translocation to the nucleus, impair the co-activator recruitment, and finally the biological responses are decreased growth, more apoptosis, reduced level of PSA. Because of several mechanisms of resistance to second generation antagonist, it is their discovery of new and new things and new modalities for prostate cancer is evolving. Coming to the chemical structure of second generation AR antagonist, the apalutamide differs with enzalutamide in terms of a pyridine ring and a methyl group, while darolutamide has got a quite different chemical scaffold. We call it as apple or banana. Are they same or different? Which I will be discussing later. Why all these changes are proposed? Probably because of gradually discovering apalutamide, darolutamide, they increase binding to the androgen receptor and thereby increasing potency. Also, inhibition of AR mutants preventing antagonist to agonist, which is one theory why these changes have been developed. Also, with the changes, the permeation to CNS has reduced, thereby leading to reduced side effects. Coming to the differences in binding properties to AR, the apalutamide in comparison to enzalutamide, greater efficacy and higher tumor to plasma ratio. It has got 4-fold lower concentration in CNS, thereby decreasing the ability to permeate the blood-brain barrier and hence lower risk of seizure activity. Darolutamide is unique. It inhibits AR nuclear translocation. It markedly increased potency over its two sisters. It specially inhibits clinically relevant AR mutations. Thereby, it prevents antagonist to agonist switch, which is there with enzalutamide and apalutamide. This is a very, very important mechanism of action why darolutamide is being in further trials. Also, it exhibited very low penetrance to blood-brain barrier and hence reducing the side effects. Coming to the pharmacokinetics and dynamics of apalutamide, the doses being given in the trials is 240 milligram per day. The tablet is 60 milligrams, so 4 tablets. With or without food can be given. Metabolism is primarily hepatic. Half-life elimination is 3 days and excretion is by urine and feces both. Darolutamide has got a half-life elimination of 20 hours. So it is administered twice daily, 600 milligram twice daily. The tablet is of a 300 milligrams, so 2 into 300 into 2. Should be administered with food. Metabolism is primarily hepatic. And the active metabolite is ketodarolutamide. Excretion is as like apalutamide, urine and feces both. If we compare side effect profile, especially for apalutamide, there are 2 important side effects one should remember. One is a skin rash, which happens in 37% of the patient in trials, and grade 1 to 2 hypothyroidism. So thyroid levels should be checked on regular intervals. While darolutamide has got the best adverse effect profiles. Why? Because darolutamide has the least blood-brain barrier crossing effect. And if we see darolutamide crosses least, followed by enzalutamide, followed by apalutamide. Coming to the pivotal trials in non-metastatic CRPC, apalutamide being approved after the Spartan trial, darolutamide after Aramis trial, and apalutamide after Titan trial in metastatic castrate-resistant prostate cancer.
3 minutes to go, sir.
Pardon? Yeah, okay.
3 minutes to go.
Okay. Apalutamide in non-metastatic CRPC, one of the important trial is Spartan trial, which approved it, which after that FDA approved it for non-metastatic castrate-resistant prostate cancer. If we look at the median metastasis-free survival secondary endpoints, it is in favor of apalutamide. And similarly, apalutamide for metastatic castrate-sensitive prostate cancer, the important trial to remember is a Titan phase 3 trial. It is a randomized, double-blind, multicentral trial. The primary endpoints are overall survival and radiographic progression-free survival. Both are better in apalutamide plus ADT group as compared to the placebo group. Even the secondary endpoints, median time to PSA progression is better in apalutamide plus ADT group. And after this trial, it has been approved further for metastatic castrate-sensitive prostate cancer.
Dr. Rahul, please.
Yeah, the major trial for darolutamide is basically Aramis trial. It also shows improved metastasis-free survival as well. And this is ongoing trial with the darolutamide. I'm skipping this. And if we see the indirect comparisons of efficacy of non-metastatic castrate-resistant prostate cancer, these 3 trials, if we see the efficacy, the primary endpoint of metastasis-free survival, apalutamide is almost equal to enzalutamide, which is better than darolutamide. Even the secondary endpoints, if we see, the median time to PSA progression is better in apalutamide and enzalutamide, and adverse events are definitely less with darolutamide. There are side effect profile with the all androgen receptor antagonists, which one should remember and
1
should
minute
carefully.
To go.
Raghavan, 7 minutes over.
Yeah. Rahul sir, can you give the final slide at the conclusion, please? Sir, we can't hear you. Dr. Rahul, we can't hear you. We have to unmute and just give the conclusion for us.
Is he linked or there is some net problem?
He says mute.
Unmute.
Yeah,
okay.
Yes, sir. So conclusion, please, sir.
Yeah, like basically all 3 drugs are like apple and bananas. They are fruits with similar patient benefits. A different structural differences distinguishing them from each other. Impossible to compare with each other, though some differences are there. And patient selection must be based on adverse effects, cost, availability, and maybe even combinations in future may benefit the therapy for prostate cancer.
Thank you so much. I request Dr. Ganesh Bakshi to take over.
So for the next talk, I invite Dr. Senthil Rajappa, a very well-known medical oncologist, chemotherapy, docetaxel, cabazitaxel, and sequencing. Over to you, sir. I think the sharing will start now.
They are not
Give it a
letting me
stop
share
sharing from Dr. Rahul's screen, please. And then only Dr. Senthil can start. Yeah, I think you should be able to.
Yes.
Yeah, we can see that.
All right. Thank you, organizers, for that. Yes, thank you, Dr. Ganesh. Organizers for calling me docetaxel, cabazitaxel, and sequencing. Now, I would equate them to either Thompson and Thompson on the left or Santa and Banta on the right, because these are people who have been with us for a long time. We've grown with them, we are happy with them, and we will continue to be with them. So here is the big list of drugs that we have, or rather we used to be there, are mitoxantrone, docetaxel, cabazitaxel, and carboplatin. We hardly use mitoxantrone these days. It's the other drugs that we use. And the focus of this talk will be predominantly on docetaxel and cabazitaxel. I put up a big list here telling you what the differences are. Now, for the urologist or the uro-oncologist, there are two important differences. One is that the cancer cells have something that we refer to as a P-glycoprotein, which extrudes the drug from within to outside. Now, docetaxel is something that can be thrown out by this P-glycoprotein, while cabazitaxel cannot be. So that's one important difference. The other thing is that cabazitaxel can get into the brain while docetaxel cannot. Now, what's the relevance of this in patients with prostate cancer? At least the part as far as the brain is concerned may not be, but the P-glycoprotein is very important. So there we go. What do we know about docetaxel in metastatic prostate cancer? I think now we have enough evidence in both low volume and high volume or high burden disease that a combination of ADT plus docetaxel is better than ADT alone. When it comes to castrate-resistant prostate cancer, docetaxel is better than mitoxantrone. Now, this betterment only when shown in this particular table. Reuse of docetaxel is discouraged because we now have evidence that there may not be good activity when you use it after HSPC into castrate prostate cancer. There's also some Asian data, the higher doses there. So that's what we know about docetaxel. What about cabazitaxel in metastatic prostate cancer? We know from the TROPIC study that cabazitaxel is better than mitoxantrone in terms of overall survival, but cabazitaxel is no better than docetaxel when you use it in the first line CRPC. There are two studies which told us that lower doses of cabazitaxel, which is 20 milligram, is as good as 25 milligram with lesser toxicity. So that's the dose that we use in day-to-day practice. Cabazitaxel is better than abiraterone, and especially if your patient lasts 12 months, using Abi or Enza in that situation is as good as using placebo. There's also a nice study called as the CONCAP study, the phase 2 study, which showed that weekly cabazitaxel is as good as 3 weekly. We earlier said that weekly docetaxel may not be as good as docetaxel. So that's one advantage of cabazitaxel over docetaxel. We don't know whether docetaxel is better than one of those AR-targeted agents for HSPC. And as I said earlier, is weekly cabazitaxel better than weekly docetaxel? And the reason why I'm talking about this more than a couple of times is because prostate cancer patients are frail and old. All of these patients may not be able to tolerate a 3-weekly schedule, which is associated with a lot of physical side effects. So we are always interested in this issue of whether weekly is better than 3-weekly. We don't have evidence towards that. Now, is there a role for any of these agents in high localized prostate cancer, we still don't have, no. Now, the other thing is the toxicity profile of docetaxel versus cabazitaxel. Now, this is from the first STANA study, and I have highlighted certain toxicities which might be a little different. Certainly looks like cabazitaxel is actually less toxic compared to docetaxel. Now, there was a nice study presented at last ASCO where patients were asked for their preference. Now, how did they ask patients for their preference? They started with docetaxel and then after 3 cycles went on to cabazitaxel, or the other way around. Now, contrary to what all of us would think, and very similar to what you saw on the first STANA study, patients actually preferred cabazitaxel much more than docetaxel. Now, all of us think that cabazitaxel is a much more toxic drug, but that's not what patients thought. And now we have a nice sequencing study to show that. So although by the regulator's approval, docetaxel comes first and cabazitaxel comes next, there's a study that I'm showing you on this table, and also a nice randomized phase 2 study which says that cabazitaxel is not as much a bad drug as what all of us would think. And then when you've exhausted all your options on Netflix, what do? You finished cabazitaxel, you finished docetaxel, you can go back to the good old carboplatin. This drug still has some activity in patients who have progressed on cabazitaxel and docetaxel. So all of us go and watch Godfather sometimes when you're exhausted with the Hindi flicks and the Telugu and the Tamil or the Kannada flicks that we keep watching all the time. So when you don't know what to do, when you've got a fit patient who can take chemotherapy, go and knock the doors of carboplatin and you are likely to get some response from there. And finally, we come to sequencing. When it comes to metastatic prostate cancer, it's the dessert or docetaxel, the D that comes before the cheeseburger, which is cabazitaxel or carboplatin. Though it's not time for dinner, let me remind you that you will soon be there. And I hope I have finished on time, handing you over to dinner faster than what you think it will. Thanks so much, Dr. Ganesh. And
thank you so much. Thank you so much, Dr. Senthil. And it was very appetizing.
Thanks. I hope the substance was good too.
I call Dr. Sanjay Adla for the next talk, sequencing of hormonal and chemotherapeutic drugs. So Sanjay, please, it's your screen.
Okay, thank you very much for the opportunity. Let's start off with someone said, reading literature and attending webinars like this gives you the knowledge to treat patients. However, treating patients makes you realize that actually sequencing is an art that you got to learn on the job. Castrate-sensitive prostate cancer. Let's see where the evidence comes from and what can be done regarding this one. So these are all the trials that have been quoted. The journey started with the Jatug AF315 trial. It was a negative trial, but that's where the evidence started from. And I've summarized all of these in the hormone-sensitive prostate cancer. So when you look at the Jatug 2013 one, the hazard ratio was 0.88, but the charted and the Stampede showed that giving docetaxel at the outset makes a difference. And if you look at the hazard ratio for the OS, it seems to be around 20-25% at max. Stampede also had locally extensive prostate cancer. There were non-metastatic prostate cancer as well. So that's where the hazard ratio was. When you look at the androgen receptor blocker, abiraterone, or the androgen receptor pathway inhibitor, when you look at ADT plus ABI versus ADT, the hazard ratio seemed to be around 0.66 or 0.61. And if you just did, we shouldn't be doing this, but if you just did a head-to-head comparison, the androgen receptor blockers seem to be doing better. Then comes the newer age one, Enzamet, as well as the Titan, apalutamide. Both of them hazard ratio of 0.67. So in just summarizing the hormone-sensitive prostate cancer, the androgen receptor medications seem to reduce the risk of death by around 35% compared to 20% by the docetaxel. And if I can say so, AR pathway medication are more effective. Then let's look at this low volume and high volume. This is what the chart it gave us, saying that they are different. And these are the studies. There are 4 studies addressing this, looking at the radiotherapy, enzalutamide, and then the abiraterone, and then the docetaxel. The first one, the Stampede RT arm, what it showed is what not to do. So don't give local RT in high volume metastatic prostate cancer. It doesn't work. In low volume metastatic prostate cancer, it gives an advantage with respect to overall survival with a hazard ratio of 0.68. And then come the abiraterone and docetaxel. Again, here if you see, abiraterone and docetaxel seem to work in both high volume and low volume to the same extent. So it doesn't matter whether someone has got high volume or low volume, both of them work. That's one. And second is the difference of around 10% to 15% seems to be persisting, especially for the high volume. If you look at abiraterone, high volume, 0.6 hazard ratio. Same with the low volume. So for abiraterone, it doesn't tend to make a difference. That's one. And second, it seems to work better in high volume if you were looking at it in a contrary way. When you look at the Enzamet was a bit skewed study because there was the docetaxel and then without docetaxel, but the numbers were staggering. If you look at the low volume hazard ratio, it is 0.43. So one thing we know it works in low volume metastatic prostate cancer, enzalutamide does tend to do a very good job. Okay. So local RT doesn't work in high volume. AR medication more effective both in high and low volume. Enza seems to work very well in low volume. High volume, especially visceral metastasis, ABI scores over Enza. However, what CRPC setting? Do I give Enza or ABI? When you look at the summary of both in the pre-docetaxel and post-docetaxel, this is comparison of both the studies, it seems to favor enzalutamide compared to abiraterone. So both in pre-docetaxel as well as post-docetaxel, Enza is slightly better with a hazard ratio of around 0.73 compared to abiraterone. If I wanted to use Enza followed by ABI or ABI followed by Enza, there is the Kyoto-Baltimore collaboration just because of the way the approvals happen. What I want you to look at is just look at the Enza one. If you use the Enza in the primary setting, it works very well. But more so if you use it in secondary setting, it does a very good job. Whereas if you use ABI in the secondary setting, it doesn't work at all. So if you wanted to sequence, the order of sequence is ABI followed by Enza, not the other way around. Summarizing, Enza is better than ABI in both pre and post docetaxel. If only one AR blocker you got to be using, use Enza. If you had to sequence, use ABI followed by Enza. Then all the knowledge we got to fit in with all this is the patient de novo metastatic or recurrent metastatic, low volume because of extrapelvic lymph nodes or bony metastasis. Somebody has got visceral metastasis. And that's where the sequencing comes in. That's where the intelligence comes in. And as I've said, reading literature and attending webinars gives you the knowledge. However, treating patient makes you realize the sequencing is an art. I didn't find it anyway, so I said it myself. Thank you very much.
Thank you, Dr. Sanjay. It was a nice talk indeed. There are no questions actually. So your art is being mastered. I invite Dr. Gagan Prakash, my colleague, for the next talk, neuroendocrine tumor of the prostate.
Thank you, sir. Good evening, everybody. So we would go to neuroendocrine tumor of the prostate. No conflicts, no disclosures. However, I would want to mention these two sources, the presentations from APCCC 2019 and this wonderful commentary from London Oncology. What we all would have seen these, not very usual, but I'm sure we would have seen these scenarios where there's a patient with a prostate but with a normal PSA, or somebody who's got visceral only metastasis, no lymph nodes, no bones, mets, or scenario where there are multiple metastases but not up on PSA, or scenario where the radiological patient are. So these tumors are essentially AR-independent cancer subtypes, and these are often known these days as treatment-related neuroendocrine prostate cancers. In the autopsy studies, it's been found that the incidence could be much more than what we've thought, even to the tune of around 25% has been reported. Typically, it has low or absent AR expression, clinically overlaps with anaplastic carcinoma, and the amount of neuroendocrine differentiation increases with the disease progression, and also correlates with patients' exposure to long-term androgen deprivation therapy. With the introduction of new androgen receptor target therapies, the incidence of these tumors could possibly be rising. We would have heard different terminologies for the same spectrum of disease. So variants of prostate cancer, probably the terminology which is getting most popular now. Then there is therapy-related neuroendocrine prostate cancer, androgen-indifferent prostate cancer, AR-negative prostate cancer, and anaplastic prostate cancer. So AVPC, which is the terminology based largely on clinico-pathological variables and probably largely going to be used more often now. Any of these 7 criteria, histologically small cell prostate carcinoma has been proven. This is the pathological one. The clinical criteria, only visceral mets, lytic bone metastasis, nodes, low the disease, or some of biomarkers or a primary this is what we be suspecting. Understanding what's happening over here. So, lineage is a which is processed by one difference of a particular in this case, first type and carcinoma. The duration or the influence is actually the androgen and this is independent neuroendocrine. Two classification used and essentially have the same things as in other small cell tumors, large cell, well-differentiated tumor. Planet cell better prognosis compared to the other types.
Gagan, your voice is breaking a lot. Yeah. Okay.
Okay. Yeah, the video has been. Is it better now?
It's better now. Yeah. Thanks.
Okay. Some uncertainties in the diagnostic evaluation. There's a lack of consensus about when to perform IMU. There are several guidelines which recommend that if the biopsy is done, it should be really done from the metastatic side rather than from the primary. Molecular subtyping information is known, but there's validation, and the scan and how to sequence whether you PSMA or a combination of PSMA with is not very well known. Treatment is central or without etoposite is something which has been considered. Still in combination with carboplatin also be considered. Now, for treatment is this particular study which has given us a lot of information about this cancer. This was published last year in and it was phase 1 trial where paclitaxel alone was compared with a combination of paclitaxel plus carboplatin. Now, what was strikingly seen over here is the tumors which had of these tumors, positive, the difference or the advantage of adding carboplatin to cabazitaxel was the most pronounced. So this was one of the most important piece of information which we gathered from this study. And there are other studies based on circulating tumor cells which also say that probably with more and more androgen deprivation therapies being used in the future, there is a possibility that the incidence of or the detection of these cancers, neuroendocrine tumors, be rising. The largest series is the systematic review which comes from China, published in 120 patients. The median time to development of around 20 months. Median survival of these patients was around 7 months. And on the multivariate analysis, it was seen that chemo with radiotherapy was better than either chemo or radiation alone or palliative therapy alone. Could one see or expect to see a neuroendocrine tumor in early prostate cancer? It has been reported around 6. So obviously, one would not, expect or go until there is a different behavior of these tumors seen. Follow up. There are issues because PSA is not reliable, so one might have to rely on either the imaging or some other markers like chromogranin A and neuron-specific enolase, which has been shown to rise in these tumors. Also, as I mentioned, the choice of nuclear imaging and the sequencing is not very certain. Carry home or carry work messages. So the clinical criteria, those 7 criteria is the ones which you should remember and always suspect this tumor when you see one of those. Several guidelines now recommend that, when you fall into these criteria, in this scenario, it would be good to take a biopsy from the metastasis. Molecular subtyping, some information is known, and the treatment should probably involve, carboplatin or cisplatin, basically platins other than Gagan. Thank you, sir.
Thank you. Thank you, Gagan. We invite Dr. Indranil Banerjee for the next talk, Bone Health, Role of DEXA-scan, Diet, Exercise and Drugs. Dr. Indranil Banerjee.
Good afternoon, everyone. As we all know that bone is the most common site of prostate cancer metastasis. So when we are taking care of prostate cancer, metastatic prostate cancer patient, we should also take care of the bone health of the patient. I will start with a standard prescription of these patients. If you see that metastatic prostate cancer, this prescription contains almost everything. I would say that it's a good prescription, but it is not comprehensive, because if I walk you through the presentation, probably you will understand why I'm saying so. Maintaining bone health is critical. On the left side, you can see the osteopenia and compression fracture related to the ADT treatment for the patient that I will be covering. On the right side, you can see because of the prostate cancer metastasis to the bone causing neural compression, that will be covered later in the palliative care. So come to the background. A recent study published in Indian Journal of Endocrinology and Metabolism by Kotman et al. Have shown that healthy men above 55 years in India, 40% are osteopenic and 8.5% osteoporotic. And if the patients are receiving androgen deprivation therapy, the risk of fracture increases. In 5 years, it is around 19%. In 15 years, it is around 40%. I will quickly go through this guideline statement. So before starting androgen deprivation therapy, we should do a baseline DEXA scan and repeat it in every 1 or 2 years, depending upon the DEXA scan results. Patient should be on calcium and vitamin D3. Regarding calcium, the patient is taking citrate, calcium citrate, which doesn't hamper the absorption. The dose can be 500 mg. If the patient is taking calcium carbonate, then the dose is 1000 mg at least. And if the DEXA scan shows there is osteopenia and any other fracture risk criteria that I will be covering later shows there is a risk of hip fracture or major fractures, then we should start the secondary preventive measures like denosumab, zoledronic acid. But this should be limited to 3 to 5 years, because it has been shown that longer you use these medicines, there is more chance of osteonecrosis of the jaw. Dental evaluation is again very important before starting these medicines, because if you are doing some dental manipulation like tooth extraction, then there will be more chances of osteonecrosis of the jaw. Surprisingly, castrate-sensitive prostate cancer, the studies has not proven, the zoledronic acid studies have not proven any benefits, so guidelines doesn't recommend it. But you can recommend 60 milligrams of denosumab every 6 monthly in this patient if they are osteopenic. But in CRPC settings, these drugs are indicated, but for how long they should be taking this medication, nobody knows, because most of these trials were designed for 2 years follow-up. Now they are getting 3 years follow-up. So probably we need to continue all these medicines. This is a fractures criteria which I was talking about. You can get it online, and it also can be a country specific, and you can get a score from it. If you look at the point number 10, is the secondary osteoporosis. If the patient is taking ADT, then it become osteoporotic, then it's secondary osteoporosis. Coming to the DEXA scan, it measures bone mineral density. It gives a T-score. T-score is important. If the patients are osteopenic or osteoporotic, then we should start the bone modifying drugs. The drugs that delay the time to skeletal events, which are pathological fracture or patient needing radiation, patient needing surgery. The drug on the right side has already been covered. I will be concentrating on the bisphosphonate and the denosumab. This was a trial, randomized control trial between denosumab and placebo. You can see on the left side. The patients are taking denosumab as compared to placebo. They have better results in the DEXA scan on the right side. There is also a small benefit in the vertebral fracture. The next study is between denosumab and zoledronic acid. You can, on the left side, you can see the Kaplan-Meier slight difference in the denosumab and zoledronic arm in terms of first skeletal event. But on the right side, there is no difference in overall survival. A point of caution for starting denosumab, it causes more hypocalcemia in these patients. So before starting denosumab, we should check the calcium level, and they may need supplementation also. The advantage of denosumab is you can give it subcutaneously as compared to the zoledronic acid, which is given intravenously. So this is the comparison between these two drugs. For the denosumab, you can be safely used in renal failure, but in GFR is less than 30-35, you cannot use the bisphosphonates. And another thing, bisphosphonates can be stopped in between because they are retained in the bone for longer duration, but denosumab you cannot stop. The patient should take it continuously. Come to the diet and lifestyle modification. Patient should take, I've already covered the calcium and vitamin D3, avoid smoking, avoid alcohol, take a lot of vegetables, take omega-3 fatty acids. And for the vitamins, they should take it from the vegetables or fruits, and they should avoid the vitamin supplementations. Patients should be encouraged to do exercises, aerobic exercises like light jogging, climbing stairs, brisk walking, and resistance training. If the patients are into exercises, they can do their resistance training, their bicep curls, other exercises. But if they are not into it, they should be referred to the exercise specialist. There is strong evidence as exercise as in medicine. There's strong evidence that in the prostate cancer patient, if they do exercises, guided exercises, there is less loss of muscle mass, and there is a moderate level of evidence that it prevents bone loss.
Last 30 seconds.
According to the American College of Sports Medicine guideline, they should have 30 minutes brisk walking at least 3 times a day and do resistance exercises. And it should be started along with the initiation of ADT. So along with the treatment of this patient, they should be referred to nutrition department, exercise department, and also to the dentist. And come to the prescription again. So the prescription should include a DEXA scan, refer to the physiotherapist, nutrition department, and the dentist. Thank you.
Thank you, Dr. Indranil Banerjee. I think we invite the expert comments from Dr. Makarand Kochikar and Dr. Hemang Bakshi.
Thank you very much. I think it was an excellent disposition of what can be sort of done in case of metastatic prostate cancer. I'm not going to dissect out the different talks as such, but want to give a piece of sort of a conclusion or opinion over the period of whatever talks we have received. In the past, we have been thinking that the metastatic prostate cancer patients do not survive for more than 18 months to 36 months. But now we know with so-called whatever drugs we discuss is called as a life prolonging medications, people survive for more than about 5 to 7 years. So what is important is choosing your medications very, very wisely. I was impressed by Dr. Anant Sivaramkrishnan's talk on bilateral orchidectomy, and I still feel it is one of the best modalities in the Indian circumstances for a variety of reasons, as he explained. So when a patient comes with a metastatic disease, you can offer him bilateral orchidectomy. You reserve all his cost for sequencing the subsequent treatment, which is expensive. That's the philosophy I feel. We have discussed about chemo, abiraterone, enzalutamide, how it is to be given. And I think the talk what we had about choosing the molecular studies comes in play at this particular time, when you want to use the newer modalities as against the conventional ones. Supportive care is extremely important. One more point I would like to make is when patients present with extensive bony metastasis, maybe you can choose ABI and ENZA rather than chemo, because a lot of chemo drugs can have a bone marrow suppression, and these patients are anemic and have bone marrow depression. We recently heard a talk and as well as publication from Lawrence Claus, and for the delegates and the PGs, I think the algorithm, what he said was A, B, C, D, E is very, very useful, very, very useful as far as metastatic disease of the prostate cancer is concerned. There was one mention about use of metformin statins, and I think he also, nobody mentioned about it, but you can use in your real practice metformin statins. Role is debatable, but still we can go about it. Now, last but not the least, we recently had this Asia Pacific meeting last year when we talked about using this drug or choosing this drug very, very wisely. We all know about St. Gallen statement. Vedang was part of this St. Gallen statement 2019. So we met in Australia last year and tried to find out what is a real life scenario in metastatic prostate cancer, both hormone sensitive or hormone refractory. So it was published in BJUI. You can refer to those guidelines. But I must say all the presentations were really excellent. We are meeting again for the follow-up of the St. Gallen statement again in October. And whenever we publish about it, we will get a real life scenario when we can use these drugs, how we can use and choose it wisely. Thank you very much. I really enjoyed it.
Yes, so Makarand has already made his points, and I would like to add a few more clinical points to those already made. Regarding the choice of hormone therapy, sometimes the clinical situation of the patient will make the decision easy. All three presenters have wonderfully argued regarding the merits and demerits of each. But suppose you have a patient with impending spinal cord compression or ureteric obstruction or acute urinary retention, then degarelix would make itself the preference of choice. I mean, some situations like these would make it easy for us and for the patients both. Then we can go on after the acute crisis is over to switching over to orchidectomy or agonist. And regarding, as Ravi rightly pointed out regarding antagonist, this oral drug, relugolix, could be a game changer very soon in the next few years, and we hope it does because the compliance issue of out of degarelix is taken out. We hope we get it soon enough. Regarding ENZA versus ABI, ENZA, the major deterrent, one would say, is the cost factor, or was the cost factor till recently, but many generic enzalutamide preparations are now available at a lesser cost, and we would see more of its use both in the pre-chemo sensitive MHSPC upfront setting as well as in the CRPC settings. One point which I would like to again mention is the theranostic part, where lutetium and actinium-based PSMA therapy could be of use in the later parts of.
We'll be covering that. We'll be covering that in the next session.
Okay. Thank you all speakers, and over to you, Raghu.
Thank you, my dear moderators. Dr. Raghavan and Dr. Ganesh managed in an excellent way, and thank you, Dr. Makarand and Dr. Hemang, for your expert comments. We'll move on to the fourth session. I invite Dr. Ginil Kumar and Sanjay Adla, the moderators, and Dr. Amit Rautal and Dr. Amit Joshi as expert commenters. Over to you, Dr. Ginil.
Yeah, thank you, Raghu. Sanjay, hope you are there. In this session, we are going on to the new molecules that has come in the market, because we know that during the long course of prostate disease, we'll be depleting the initial molecules at one point of time. So new molecules are required for further management. We have got new entries in the market in this aspect. These are more of individualized treatment based on some particular markers. So the first talk is on PARP inhibitors by Vineet Talwar, the renowned medical oncologist from Rajiv Gandhi, Delhi. So over to you, Dr. Vineet.
We are behind schedule by 13 minutes. Please cover properly. Thank you.
Thank you so much. And am I audible?
Yes.
Yeah.
You can.
So I've been given 6 to 7 minutes to cover a huge topic of PARP inhibitors in prostate. I hope I'll be able to do justice to that. So what I was told was what is PARP, where it is used, and how it is brought into practice. So I have broken into two parts, like what is PARP and how it is used. So we have BRCA1 and BRCA2 genes. All of us know that these genes are inherited in an autosomal dominant fashion. There are several mutations which have been reported in these genes, and that is why you see these mutations in a plethora of organs, whether it is breast, ovary, prostate, and pancreas. And there are mutations which are far greater in selected populations, especially the Ashkenazi Jews, for an example, and a few of our Muslim communities in India. So all of us know again that only germline mutations are passed on to offspring, and somatic are the basically locally and the disseminated clones. These germline mutations are present in all the cells of the body, and you test them with blood or saliva, whereas somatic mutations are only tested on the tumor tissue per se. So what are the normal functions of BRCA genes? They repair the double strand breaks, and by doing that, they facilitate the recombination with the undamaged or the homologies of the DNA strands. The importance of this pathway is seen when DNA damage is there in the prostate carcinoma, and when this damage occurs, there is an inability of the cells to repair the sub-post lethal DNA damage. So there is a constant harmony which is going on between the damaged and the repaired DNAs. Sometimes you have a perfect repair, sometimes you might have an imperfect repair where you might have a mutation, and that may lead to subsequent carcinogenesis, which I'll tell you subsequently. Or if it is failed, that leads to cell death. So the mechanism of BRCA mutations, there is always a predisposition. The BRCA genes per se, as all of us know, it acts as a tumor suppressor gene. And this is based on the famous Knutson's double hit hypothesis. Now in this, there are two hits. First is the germline hit, which is represented by the inherited mutation which occurs per se. And that leads to an interface with the DNA repair function of the normal gene. Now, when you have this first hit, that is the inherited germline mutation, you have an accumulation of the chromosomal abnormalities, which keeps on adding on and on and on. And on top of that, if you have a defect in a second allele, that leads to the cancerization or the cancer propagation. So this Knutson's double hit hypothesis is the one which is used when we go about blocking these mutations. So where does PARP come in? In a normal situation, as you've already seen, you have a single strand damage or you have a double strand damage, the PARP binds to the DNA, the PARP modifies itself, and after that, once the repair is complete, the PARP detaches. Now, when PARP inhibitors are there, there is no detachment that leads to a PARP trap. When PARP trap occurs, that is the time, when that leads to cell death in abnormal DNA combinations. The other pathway, one is the single strand pathway, other is the double strand damage. And that also, you can have the same, that is the homologous recombination, or you can have NHEJ, that is non-homologous end joining. So it is the NHEJ where, the ends get chewed back and glued back together, and they might have some mutation in them. And these repairs induce deletions, and a blockage of this by, again, the PARP drugs leads to blockage of the tumor propagation. Family history, again, unfortunately, in a CA prostate does not play an important role if you take the history of prostate cancer per se in an individual. You have to take in account the breast and ovarian cancer histories also. Why? Because most of the BRCA mutations are found in women in the family. So this is a very, very important point. Whenever you take a family history, wherever you come across a patient of prostate cancer, because you may not find that in the person or the males, you have to go about and dig deep into the history with the breast and ovarian cancers also. Saying that, 11.8% of these metastatic prostate cancer patients had germline DNA repair defects in this study. And here again, it was again reiterated what I have told you, that not all men with germline mutation had a family history. Suffice to say that you have to look for other people in the family, the females, to look for breast or ovarian cancer history. So when you look at all these germline mutations, you find that majority of them are BRCA1 and 2 in these. And the most preponderant of them are the somatic mutations as compared to the germline mutations, which in turn feels that whenever you check for these mutations, you have to check the tissue also, because if you check only the blood or saliva, in which you check only the germline mutations, you might miss the somatic mutations, which according to the study has higher preponderance. The others which have a higher preponderance are the Czech and the PAL-B2 genes. So you have a plethora of drugs now, and the study, which was the PROFOUND study, it had a cohort of BRCA1 and BRCA2 and ATM mutations versus the other alterations. And both of these patients were given olaparib 300 milligrams twice a day. And the primary endpoint was the radiological progression-free survival. And the secondary key points were the toxicity profile also. And you find here there is a significant difference in the radiological progression-free survival in those cohorts in which BRCA1 and BRCA2 genes are preponderant. In the others also, it was there, but it is not that preponderant. So FDA approved olaparib for these patients. The other molecule, which is rucaparib, that was also tested, but it was only tested for BRCA1 and BRCA2. And it also found that there was an overall response rates in these patients. So two drugs, olaparib and rucaparib, have been given FDA approval as of now. And there are other studies which are going on talazoparib and niraparib also. The results will be approved later on. So this is my last slide. How are PARP inhibitors used in prostate cancer? They are used in the treatment of metastatic CRPC only, castrate-resistant prostate cancer. And they target BRCA1, BRCA2, PAL-B2, ATM, which are the most common genes. And all these four genes, according to the various studies, account to almost 75% of the mutations which are occurring. So when you target these, as it was seen in the PROFOUND study. Sequencing, when they should be put into work, after the AR targeted therapy, that is either you give abiraterone or enzalutamide, after that.
Thank you, Dr. Vineet.
Okay, I'm going to request, because we don't have time for the questions, we'll wait for the expert comments at the end. I'm going to request Senthil Rajappa sir to enlighten us, as he normally does, about a new thing, that is the immune checkpoint inhibitors. Thank you very much, sir.
Thanks, Sanjay. And thanks, organizers, for having me again to speak on a topic. And the topic is immune checkpoint inhibitors. What should a urologist or a uro-oncologist know? So I think let's make it as simple as possible. All of us have stepped hard.
There is
yes, Sanjay, you were saying something.
Do you want to stop the video transmission of yours? Because there is a problem with the voice.
Oh, yeah, sure.
It's done, sir.
Okay, is it okay now?
Yes, sir.
Okay, thanks. So let's not waste any more time there. So the players in this game are the T cells, the tumor cells, and the antigen presenting cells. Now, in a car, you've got some accelerator, you've got the brake. So when the activating receptors in these sets of cells get activated, that's the accelerator. Whenever you've got the inhibitory receptors that come into play, these are the brakes. So let's get to that car that's sitting there. Now, the T cell, which is very important for anti-tumor immunity, is the engine. You've got the cytokines at the back, which is the fuel here, and the points are the brakes here. So in order for your immunity to kick off, you need to release the pedal. So when you release that brake pedal, the activating receptors or the accelerators will get or combine, and the car starts moving, which is your anti-tumor immunity. Now, what do you do here in order to release the brakes? You just use some antibodies to these brakes or these molecules, and these are what you refer to as immune checkpoint inhibitors. Now, in the picture that I'm showing here, you've got the T cell on the left, the cancer cell on the right. The inhibitory receptors are the PD-1 and the PD-L1. Now, when the PD-1 and the PD-L1 combine, what you get is an inhibitory. So what do? You use an antibody. So you've got the brakes off, you've got that pedal off, so these cytokines kick it on, and then you get on to your anti-tumor immunity. What are the antibodies that are available? You get anti-PD-1 or anti-PD-L1. PD stands for program death. PDL is program death line. So there's a 1, there's a 2. Anti-CTLA-4 is cytotoxic T lymphocyte antigen. Okay, so these are complicated names and complicated ways of calling these names, and that's why I put the picture of Shashi Tharoor there, because all these names are really difficult to pronounce for all of us, including medical oncologists. So I'm not going to go through this list there. That's for you to see. Let's get on to the indications in uro-oncology. You've got urothelial cancer indications, you've got renal cell cancer. In renal cell, you've got approvals only for the clear cell. And then there's something that we refer to as microsatellite instability. If you've got a high microsatellite instability, then irrespective of which subsite is it, you can use an immune checkpoint inhibitor. Now, in urothelial cancer, you got an indication for pembrolizumab in high-grade, non-muscle invasive bladder cancer that's not responsive to BCG, and your patient declines a cystectomy. What a long indication that is. That's as complicated as it can sound. You can also use this in stage 4 disease for first-line platinum-ineligible agents if you've got a PD-L1 that's positive. Now, that's a marker that you can do. The most recent approval is for a drug that's called avelumab, which is used as maintenance therapy after first-line platinum-based chemotherapy. And then there is a second-line indication wherein all immune checkpoint inhibitors are actually approved. So those are approved patients with urothelial cancer. What about renal cancer in patients in first line? If you've got somebody with intermediate or poor risk, then they could use combinations. It looks like axitinib and pembrolizumab is also approved for patients who are good risk. In second line patients post a VEGF TKI, nivolumab is approved because it's been shown to improve overall survival benefit. Now, are there predictive markers? Now, what are predictive markers? Predictive markers are markers or tests that you can do in order to find out whether your patient will benefit from this expensive and potentially toxic drug. Now, the only test that a urologist and at least most oncologists need to know is a test that's called PD-L1. What is this? This is an immunohistochemistry test that can be simply done in many labs in the country, where you look for programmed death ligand 1. So that's called PD-L1 testing. In certain indications, you need to have a PD-L1 that's positive in order to use the drug, and the classic indication is first-line metastatic urothelial cancer ineligible for platinum. Microsatellite instability is another test which you can do by immunohistochemistry. You can do a PCR, or you can do a next generation sequencing, and there are many more. These are the only two things that you need to know. Now, all of us think that immune checkpoint inhibitors are easy to use and it's as simple as water flowing, but it's not. You can get all these toxicities. All medical oncologists are retraining themselves to be internists again, because these are immune-related side effects. Now, when you release the brakes, what can happen? Your immune system can go amok. Now, when it goes amok, it can go and cause autoimmune phenomenon in any part of the body, and you have to be extremely vigilant to make sure that you don't miss all of these.
Please conclude, sir.
And before I end, you need to know these two people who are there in your gentleman is James Allison, and the lady is certainly origin, she's not Indian anymore, but based in the West Indies, and they are husband and wife. Now, the reason why I'm showing the lady whose name is Dr. Padmini Sharma is most of the immune checkpoint inhibitor trials in urothelial cancer have been done by this lady, and there they got together in MD Anderson and got married. Now, if you want to know something that's flamboyant, that's what you're seeing. This is James Allison's car, and look at his number plate. It's CTLA4, that cytotoxic T lymphocyte antigen 4. And the left is not, the one on the left of your screen is certainly not me, but look at that number plate, it is T cells. And Padmini Sharma's number plate, which is ICOS, which is another molecule that she discovered. And these are all things that have been used as part of the immune. So if you have not understood anything else that I said, this is something for you to enjoy and take home today. Thanks so much. I hand it over back to the organizers.
Thank you very much, sir. I would leave expert comments towards the end because this is all medical oncology. You have made us more aware of where the next future is going to be. Ginil, do you want to introduce the next one?
Yeah, you proceed, Sanjay.
Okay, I'm going to request Dr. Kallur to talk about the most up and coming and the current standard in HCG, which is the theranostics. Thank you, sir.
Good evening. Now I'll talk about theranostics in carcinoma prostate. What is theranostics? You have a diagnostic evidence, that is a PSMA scan. So we just change the isotope which is meant for diagnosis, and with we put a therapeutic isotope, either lutetium or actinium. So it will go only to the metastatic disease and it will give a significant radiation. So what are the indications for the theranostics now? First, it should be metastatic castrate-resistant disease.
It's not seen.
Please share the screen. Okay, just a minute.
It's not seen.
Now?
Yes.
You see?
Yeah. Make it full screen and
yes. Is it okay? Yeah. So theranostics is there is a diagnostic evidence by PSMA scan. We just change the diagnostic molecule and put a therapeutic isotope, and it will go to the metastatic sites. It will not go anywhere else, and you will get a good response when we are avoiding the radiation to the normal surrounding tissue. So the indications are, it should be metastatic castrate-resistant disease, progressive, and after initial hormonal therapy, and it is progressive even on newly developed hormone therapies such as abiraterone and enzalutamide, and it is a progressive disease despite all the chemotherapy regimens. And in the centers who are using radium-223, and radium-223 is only for skeletal metastasis. Suppose the patient has a visceral organ metastasis, then radium-223 is not to be used. So the patients who are not suitable for radium-223 are going to be treated with lutetium or actinium. So what is the rationale? Prostate cancer is a radiosensitive tumor, and the potential advantage is we are giving a dose to the high dose to the tumor and no dose to the surrounding tissue. Many ligands have been developed, and those who are not read are currently in vogue, that is lutetium-177 and actinium-225, both are tagged to PSMA. So I request you to see only concentrate on these two images. Very simple. When you come across a progressive disease with the isolated metastasis here and there scattered, you better use lutetium-177. And when there is extensive disease, complete marrow involvement, better use is actinium-225. And there are certain predictors of responses for theranostics. What are those? Suppose the patient has responded earlier for hormonal therapy for a longer duration. These patients are known to respond better with theranostics. Elderly patients are responding better than compared to younger patients. Bone and lymph node metastasis, they respond better. Among the visceral metastasis, lung metastasis, patients do very well, as well as bone metastasis. But the patients presenting with liver metastasis are not doing well with the theranostics. And PSA with lower volume disease, they do better. And BRCA negative patients are doing better. So before we do it, we always have to do a FDG scan to know if there is an FDG uptake in the known metastatic disease. The middle one is the PSMA scan, and you are seeing the FDG uptake even in those metastases. These patients are not going to do well. They respond, but they are not going to do well. And this is a new kit on the blog, and it's called as FAPI scan. Not many of centers are aware of it. We are doing it here in Bangalore. This is fibroblast activating protein inhibitor. This is expressed only in cancer cells. This is maybe a game changer for all malignancies in another few years' time. So what are the preparations before we do the isotopic therapies? PSMA PET scan is mandatory. FDG PET scan to know the prognostic value, and renogram will do to rule out any obstructive uropathy. The blood count should be normal, platelet count should be normal, creatinine should be less than 2, and patient should have reasonably good Karnofsky status. And if the patients are already on ADT, especially on enzalutamide or abiraterone, we continue to ask the patient to continue the therapy, because these drugs are known to increase the PSMA expression in the tumor, in the metastatic disease. If the PSMA expression is more, there is more accumulation of the isotope which we give, and it may give a better benefit. Bone marrow suppression is only mild, transient. And what are the effects of these therapies? There is a decline of PSA observed in almost 70% of patients, and some patients it can be less than, even more than 50% decline. There is mild hematotoxicity. We don't see a significant nephrotoxicity or hepatotoxicity. Just to give an example, this patient, how it progressed from 2014 up to 2013 to 14, he was progressing on all the therapies. And the left side, you are seeing a PSMA scan, and the right side is a lutetium PSMA, which we are given, and it is accumulating in all the metastatic disease. And this is a result. 2014 October, and 3 months later, good response. And what are the drawbacks with lutetium? In spite of such a good results, about 60% of patients only respond, and 40% don't respond that well. And this is how we have started evaluating new isotopes, and actinium-225 PSMA is the new one. This is to be used when everything fails. We call it as TINA patient. There is no alternative. We are using it. What it does, it causes significant DNA double-strand break. And we had a tough time to convince our ethics committee. I took nearly 1.5 years to convince, and it had started already in 2014 in Germany. And in 2015, we got the ethics approval, and we called those German guys here and honed our skill to synthesize this, and we started using it. This was the paper which published in 2014-15, and they showed a remarkable improvement in the patients who was having this much of disease, and after 2 or 3 doses of PSMA actinium, there was a significant response. And this is how we are seeing good response. And there is a new thing coming, upfront therapy, when there is no other therapy is given, no hormone, no chemotherapy, no radiotherapy, no surgery. They are trying this. Some papers have started coming. This is one of our own case where the patients responded dramatically. You can see the metastatic disease, and they are responded well. This is another case where there is a good response. And the complication with actinium is xerostomia. And overall survival benefit is about, you can see about 14 months. And survival can be up to 28 months. These are the patients who have failed in all other therapies. And the summary is, targeted alpha therapy is the new one. It almost uniformly causes improvement in quality of life, well tolerated. Xerostomia is the only side effect. No significant nephrotoxicity, minimal myelosuppression, recovers well. Duration of response, they are seeing now up to 2 years. More long-term studies are required. And in future, this may be the game changer for all the malignancies, including urological malignancies. And it is called as a FAPI scan and a FAPI therapy. And we will be hearing more in coming years. Thank you.
Thank you, Dr. Kalur. Actually, we don't know where we have to fit in theranostic, but we are sure that it is coming into the guideline in the near future. So after all these three excellent talks, we have two eminent faculty, Dr. Amit Gautam and Amit Joshi, to just to give an overview and give comment on the different talks.
Dr. Amit, you will start.
Both are Amit. I think Amit.
And how
then you can start. Oh.
Yeah, Amit.
Dr. Amit, you start.
Yeah. So I think Dr. Vineet Talwar had clearly explained about how these PARP inhibitors are being used, and with the current approval of US FDA in May 2020, I think now it has become now the standard of care. And what the important message from is that now the BRCA testing has now become a routine, at least in patients who are becoming CRPC. So the patient will have an option at some point of time at the time of progression. And like he mentioned that a somatic mutation first and then a germline mutation can be considered, because most of the time to detect a somatic mutation is easy than the germline mutation in peripheral blood. So the role of PARP inhibitor is upcoming, and there are other clearly trials are ongoing where the combination of PARP inhibitor with AR inhibitor and combination of PARP inhibitor with immunotherapy. So I think next 2 or 3 years we will have some other combination of PARP inhibitor with existing therapies. And only the limitation is the cost. And I think with the use like the enzalutamide cost has come down significantly, and so in due course of time we can have a improvement in this part of also. Regarding the MSI, the immunotherapy drugs, which the Senthil has in a very lucid manner has illustrated the role of various immunotherapeutic agents, and at least the important message from him that the MSI should be tested at least in patients who can afford it. And in prostate cancer, the incidence of this MSI can range from 3%. So out of 100 patients, if you do 3 patients can benefit it, and the benefit of immunotherapy, as we all know, some patients will get some long-term control. So at least there is an option in patients who can afford it, and patients who can afford definitely should be considered for MSI testing. Regarding the third talk, theranostic, it is coming in a very big way, and for last 3 years, various studies have been conducted, and now at least in our part of in this country, lutetium PSA has become a standard care, at least in patients who have a progressive disease after chemotherapy or who does not want to take the chemotherapy. So the lutetium PSMA has become integral part of a management of a prostatic cancer, and there is very good randomized phase 2 data of from the Australian group of nuclear medicine, which they have compared that a patient who received the cabazitaxel versus lutetium PSA patient who received lutetium PSMA has a better PSA control. So I think in next 2 or 3 years we can have some other very good data regarding the use of lutetium PSMA in prostate cancer. Over to Amit Rotham.
Thank you, Dr. Amit. So we've heard the 3 wonderful talks, and Dr. Amit has summarized everything for us. So I don't think I will repeat much. I will just tell for prostate, please do BRCA mutation testing. You do germline, do somatic. If you have the ability to do it, germline can be done easily. So please do BRCA mutation testing. It is going to benefit the family, and it is also going to benefit the patient. We don't know HRD testing as of now. So those patients, we probably will not be as of now offering PARP, but maybe yes, down the line, we've seen the data. So we may be offering olaparib to even the HRD positive patients, even if they are BRCA negative. Immunotherapy, Dr. Senthil gave us the mechanism of action, but he also warned us we kind of think they're innocent drugs, but they can have a lot of side effects if we are not careful. As medical oncologists, we are learning this, that please watch your patients very carefully with immunotherapy. You will have one odd patient who will have sudden side effects, and the side effects may become life-threatening. So don't ignore these thinking they are very good drugs. They are very, very good. They are very potent. They can give you a very durable response, but if you are very complacent, you will miss the side effect, and the side effect will become life-threatening. But otherwise, immunotherapy has a very important role to play. We have seen the benefits in RCC. We have seen the way we have gone now in bladder cancer. We have seen how the maintenance in bladder cancer has come up. So the immunotherapy will have a very important role to play in all our urological malignancies. And lastly, Dr. Kalur, a wonderful talk. We had lutetium. We've been using lutetium for some years, but we have actually had experience with Dr. Kalur's experience with actinium, and some of our patients have seen the benefit which Dr. Kalur has shown us. This is going to be the future for prostate cancer patients. It opens up one other avenue. We have multiple avenues, and this is one more avenue for our patients. So I think this way we will improve survival for our prostate cancer patients much more for a longer time. Thank you very much. Thank you, Dr. Raghunath.
Thank you very
We
much.
have come to the end of the session 4. I thank moderators Dr. Ginil Kumar and Dr. Sanjay Adla, and experts Dr. Amit, both Amits. So we will move on to the 5th session, which is most important session for most of our clinicians, because these topics are not discussed very widely in any webinars. That is palliative care. This is neglected in India, and this is very important in our clinical practice. We have very eminent faculty. I invite moderators Dr. Anish Srivatsava and Dr. Jiten Jaipuria, and experts Dr. Jagadish Kulkarni sir and Dr. Anant Kumar sir. Over to you, Dr. Anish and Dr. Jiten.
So thank you, Raghunath, and good evening to everyone. I reiterate what Raghunath has told just now. We all have seen and learned the natural course of cancer prostate many times, from localized to the end of life care. This is a very important topic because the palliative care or the neurosurgical perspective or the radiotherapy may have to be pitched in any time before. It's not, at the end of the spectrum of care. We might have a metastatic cancer prostate where we might have a fracture, imminent spinal fracture, or a metastasis or a compression looking at us. So we might need something, a radiotherapy. So I welcome all the experts in this area, which is very important. And may I request Dr. Kashyap, please, to start with the palliative urological surgeries. Thank you. He is the very well-renowned neurosurgeon, works in Jahangir Hospital and in Pune. Please welcome him.
Thank you, Dr. Srivastava, sir. Palliative urological surgeries in metastatic prostate cancer form a significant burden in the patient's journey of a metastatic prostate cancer. I have nothing to disclose in this. If we look at the complications, what happened in the final years of men dying from advanced prostate cancer, the major complications urological are lower urinary tract obstruction, hematuria, obstructive uropathy, renal failure, anemia, bony pains. This was a paper from, if you look at the burden of the problem, about 20 years patient data was retrieved, and they looked at how many patients required urological procedures. So this was about patients dying of prostate cancer. So among 280 patients dying of prostate cancer, 52 patients required 153 urological procedures, almost 2 to 3 procedures per person during the last 3 years of life. And the most frequent urological procedures were nephrostomy tubes for obstruction, canal TURPs, catheterizations. The frequency of the procedures increased as the patient inched closer to the death. So various interventions available are channel TURP for obstructive LUTs, urethral catheterization or long-term SPCs for LUTs, hematuria interventions, obstructive uropathy, renal failure management, pain and palliative care, and miscellaneous procedures. Before any intervention in these patients, one should assess performance status of the patient, assess the expected longevity, look for a medical and anesthesia fitness, assess what the patient and the family expects, explain in very clear terms the palliative nature of the intervention, discuss alternatives if possible, and if these are feasible. Most important, one should provide very realistic outcomes and potential complications of any intervention. Now, channel TURP, by definition, we all know, is a resection of the visually obstructing tissue without extension to the capsule of the prostate. This is basically to improve the voiding symptoms. But whenever you do a channel TURP, one should do a preliminary cystoscopy. It's important to assess the extension of the disease beyond the sphincter. If you look in this picture, there is a tumor extending beyond the external sphincter on the right side. This is viewed from the bulbar urethra. If you go in, this is the area of the sphincter. So if you continue to resect here, you are likely to injure the sphincter and likely to you may relieve his obstruction, but may give him an incontinence. When you do a typical channel TURP, there is a typical fluffy, necrotic, irregular vascular tissue in the prostatic fossa. Don't forget to look at the tissue on the anterior wall hanging from the bladder neck. You need to resect all to achieve a good flow. Urethral catheterizations or a long-term SPC can be a good option for frail, unfit, and unwilling patients with limited life expectancy. Suprapubic cystostomy can be suitable for urethral strictures, or a bladder neck stenosis can be done under local or ultrasound guidance, or with or without a cystoscopic visualization. One should emphasize the regular change of catheter and a catheter hygiene, adequate fluid intake to prevent concretions. Hematuria interventions. The etiology of hematuria can be multifactorial. It can be a recurrent local mass, or there could be a prior history of a local therapy like a local radiation, most commonly for a bulky prostate, as we discussed earlier in the seminar. It could be a post-TURP or a very rarely following post-radical prostatectomy, or he could have had no local therapy. He just had a hormonal blockade. Another cause can be radiation-induced hemorrhagic cystitis, can happen in about 15 to 20% of the patients. It's important to recognize and can be effectively treated. Coagulopathy could be a cause, rarely new bladder tumors. The severity of hematuria varies from mild to severe to sometimes clot retention and even presenting in obstructive uropathy. In milder cases, you could give anti-androgens or dutasteride, but many of the times a cystoscopic evaluation and intervention is needed for severe cases. A local hemostatic RT, either single fraction or multiple fraction, can be added to reduce the chance of recurrence after clot evacuation. Hyperbaric oxygen therapy is a very useful tool for radiation-induced hemorrhagic cystitis. Obviously, you need to have a preliminary diagnosis by a diagnostic cystoscopy. There have been case reports of selective prostatic arterial embolizations or angioembolization. Important points about cystoscopic clot evacuations. You must correct anemia and correct coagulopathy if present, preferably under anesthesia using a large cystoscopy or TUR sheath. It's your own preference to use a 2 ml glass syringe or Helix evacuator. I prefer 2 ml glass syringe because infiltrated sticky clots are much easier to suck them out with a 2 ml glass than a Helix evacuator. You may require to do a channel TURP at the same time to control some hemostasis. Achieve as good a hemostasis as possible, a post-op irrigation. If necessary, consider a large bore SPC, and more important, this can recur. Do consider giving an early local hemostatic RT that might buy you some time. Obstructive uropathy in metastatic prostate cancer can be effectively relieved based upon how early we intervene, whether either by stents or nephrostomy tubes. Preferred are cystoscopy, retrograde degescenting, but you may require a channel TURP if the orifices sometimes are not clear in a bulky prostate like this. Orifices may be difficult or impossible to identify. You may inject a methyl blue, indocarmine, or if you have already a PCN in place, you might inject a betadine solution. Metallic stents can be a long-standing option, but they can also cause obstruction and can get blocked. Expensive, obviously. Bilateral PCN or antegrade stenting may sometimes an easier option in some cases. The question is whether a permanent PCN, but it's a cumbersome option with its attendant risks and complications. Urinary diversions, just mentioned, generally not used. The other question to realize is, should we treat all obstructive uropathies? Because sometimes uric encephalopathy might be a kinder way of device in some patients. It should be obviously a shared informed decision. Pelvic obstruction syndromes do develop in these patients, like lymphatic blockage causing fiedler, lower leg edema, suprapubic edema. Ensure Hartmann blockade, or if a large pelvic mass, you can consider a local RT or a systemic chemotherapy. It's not utilized till now. Rectal obstruction or rectal irritation can be due to a large pelvic mass. Again, an SBRT can be palliative. Don't hesitate to discuss with the radiation oncologist.
Can the admin unmute Dr. Kashyap?
Yeah, I'm just about to complete. I can't change the slide. Okay. Pain and palliative management will be covered. Some mistless interventions, sometimes like prosthetic stents, I've already covered. In summary, The average lifespan in the symptomatic CRPC patient post-therapy is limited, generally less than a year. You should provide best supportive, palliative, and compassionate care with appropriate and timely interventions, shared decision-making, and goal is to keep the patient tubeless, pain-free, with acceptable quality of life in the comfort of his home. Thank you very much.
Yeah, thank you, Dr. Kashyapi, for enlightening us. May I invite now Dr. Praveen KS for telling us about the neurosurgical perspectives. He is a chief of neurosurgery from the Trustwell Hospital, Bangalore, and has done fellowship in spine and has an experience. Dr. Praveen KS, please. Yeah, you are very well seen. You can start. Dr. Praveen?
Dr. Praveen?
Your screen is very well seen to us.
Sir, we cannot hear you.
Dr. Praveen probably needs to unmute himself, I think. Is that right, Raghunath?
Dr. Praveen, let me see, sir.
If there is an issue, maybe we can take the radiotherapy talk first till that issue is resolved.
No, he's. Dr. Praveen, can you hear us?
Sir, we cannot hear you.
Can't hear him.
Sir, can you use a different mic?
Yeah, please move on to the second next session. Praveen can join later.
Okay. Okay, shall we go ahead with the third speaker?
Yes, sir.
Okay.
I need to be able to share the screen, so if you can.
Okay.
Thank you.
Right. So, I welcome Dr. Srinivas, who is the Chief of Radiation Oncology and the lead auto-oncology from Apollo Proton Cancer Center in Chennai. So, Dr. Srinivas, please.
Thank you, sir. Palliative radiotherapy is probably the most commonly used palliative modality in advanced prostate cancers. And we all know that palliative RT is used for bone metastasis and spinal cord compression, but there are also certain other indications such as bladder outflow obstruction, compression symptoms, not just in the bladder neck, but other situations, other locations, hemostatic RT where the bleeding is uncontrolled, or visceral metastasis where it could be in the brain, it could be in the lung, liver, or adrenals. If you see the goals of palliative RT, I think Dr. Kashyapi already beautifully mentioned, it basically we still have to align to the goals of palliation, and the goals of palliative RT are also to rapidly and durably give symptom relief. We obviously should not have much side effects. The treatment time and the hospitalization should be minimal. But there is also a dichotomy of palliative radiation therapy because at one group of patients we want tumor effect, possibly a durable response in the tumor, which is actually related to the dose. So higher the dose, higher is the durable response and higher is the response rate itself. But palliative effect does not closely related to the dose. So the dose, you may not have to give very high doses for a palliative effect. So it was very well articulated whether to do a sign-based palliative RT versus symptom-based palliative RT. Symptom-based palliative RT is when you don't want an overall effect on disease, but you only want to alleviate the symptoms. And therein the side effects are not acceptable. So we don't give very large doses. We don't have to give very fancy techniques. But when we are dealing with palliation of signs of progression of disease, where local control could be a factor, where we want to prevent the onset of symptoms and possibly prolong life, there we could accept certain small side effect burden. And therein we have to give a higher biologically equivalent dose and consider more conformal treatments. There are multiple mechanisms of cytokines and growth factors and hormones which play a role in a balance between whether a metastasis is osteolytic in the bone or osteoblastic, which is a more common scenario. But if you see the palliative RT recommendations from American Society of Radiation Oncology, this beautifully summarizes because there are multiple randomized controlled trials, multiple meta-analysis, multiple prospective and retrospective observational studies, but answering one key question, whether you need a single fraction or you need multiple sittings of radiation. And all of them point to one fact, that the pain relief is equivalent between single fraction versus multiple fraction, whether you use 20-in-5 or 24-in-6 or 30-in-10, the pain response is equivalent. But there is some difference between single fraction and multi-fraction. Single fraction, it is associated with slightly higher rate of pain flare. There are definitely about 20 to 25% require retreatment. The fracture risk is more, especially in long bones, but the multiple fraction regimen is associated with slightly higher toxicity than single fraction. So single fraction is a standard of care, but I would not be considering single fraction in these situations, such as those which where the need for retreatment would be problematic, or in patients who had previously radiated to the spine, or where the fracture risk is higher, or they have undergone a surgical stabilization, there is an implant. I wouldn't want to give a single fraction. Also, of course, spinal cord compression or cauda equina compression or nerve pain, there I would not give a single fraction. There is also good literature regarding bladder outflow obstruction, large prostates, and in fact, there is a review, a meta-analysis also, which proves that a significant portion of patients have a good symptomatic relief in terms of ureteric obstruction, urinary outlet obstruction, and a lot of them have pain symptoms relief as well. Also, it is not just pure palliation, but even in castrate-resistant prostate cancer, I think very similar to theranostics, what Dr. Kallur showed, that in a group of patients who are probably non-metastatic, localized castrate-resistant prostate cancer, there is some data that high-dose palliative RT, this study showed that if you don't give a dose of higher than 40 gray, it provides high rates of local control. Some patients even have extended survival without evidence of local disease progression. And there is some literature in castrate-resistant prostate cancer, I just summarized it, that palliative RT could result in biochemical responses. We can see PSA responses, sometimes even restoration of response to systemic therapy. That is, a patient received docetaxel and then somehow did not respond, became resistant, and then you give RT, and then patients become resensitized to systemic therapy. So there could be some radiation-induced modulation or anti-tumor immune response in play. So to conclude, radiation is an effective tool for palliation of symptoms. Single or multiple fractions are equivalent in terms of pain relief. Re-radiation sometimes induces pain response in nearly half of patients. So it is useful. For more diffuse metastasis, we use hemi-body radiation, or of course, as Dr. Kallur mentioned, systemic radiopharmaceuticals are one of the options. Radium is associated with improved survival. We already know that. So there is a proof of principle that radiation is effective. And in situations such as hematuria, bladder outflow obstruction, rectal compression are all improved with palliative RT. And ability of SBRT to reduce pain compared with standard EBRT is being investigated. So is it required? A very high doses, is it required, is being questioned. Thank you so much.
Dr. Praveen is ready with the next presentation.
Dr. Praveen, ready?
Yes, sir.
Okay.
Are you able to hear me now? Are you able to hear me now?
Yes, yes. Please go ahead.
Yeah, I'm just sharing the slideshow.
Yes, sir.
Yes. Yeah. My topic is on spinal compression and fracture, a neurosurgical perspective. I'll try to keep my topic limited to the purview of the urologist, as to just give you enough information when to refer, what type of patient to refer, and once you refer, what happens in the mind of a neurosurgeon and how he sees that patient. As we have already understood, the burden of disease is significant in these advanced cancer patients. What is significant is many of them, many patients who have normal neurology without any paraplegia or sensory disturbances can still have significant occult cord compression, which happens in about 32% of the patients. So these are the patients to watch out for. And significant quality of life issues and cost issues can be involved in managing, and this is a significant burden on the society. So we have some specific facts about the pathology in the spine. As we all know, the commonest site is from the vertebral body through the Baxter's venous plexus. Commonest site is being thoracic, followed by lumbar, followed by cervical disease. Thankfully, this being the case, most patients don't have quadriplegia, but may have paraplegia or paraparesis. What is again important is that 13% of the patients can have multiple discontinuous levels. For example, the importance of this is if a patient has come, say, with an MRI of the lumbosacral spine and you find disease, we have to screen the rest of the spine and make sure that there are no discontinuous levels present elsewhere, which could be more threatening than the disease which is initially seen in a scan that the patient has come with. Most of the symptoms do happen because of a fracture or because of soft tissue compressing either the root or spinal cord itself. One speciality of a prostatic metastasis as compared to the other metastasis in the spine that we see is that the majority of them can be osteoblastic because of the osteoblastic response the metastasis create in the bone. And many of them, or 56% of them, can be osteoblastic. The importance of this is, luckily, fortunately, the incidence of imminent fracture is lesser to that extent. However, the soft tissue component can press extradurally into the spinal cord and then cause symptoms. Having said that, osteolytic metastases do happen and then they can produce severe fracture or pedicle fracture leading to symptoms. Rare forms of these disease can present as soft tissue compression involving intradural extramedullary part of the spinal cord, or very rarely leptomeningeal carcinomatosis is also known. Some images that I can show you a little later. Mostly, as I said, the clinical presentation, they present with backache and also soft tissue compression leading to root compression, radicular pain in the lower limbs, or also because of spinal cord compression, they can present with muscle weakness in both the lower limbs, paraplegia or quadriparesis. Sensory disturbances, what is important again here is the presence of bladder incontinence. Many of these patients already have LUTS, as has been extensively discussed, and differentiating the spine compression, bladder incontinence, and a patient with prostatic cancer producing obstructive symptoms is very, very important. Any small doubt, we have to image and then find out whether the cause is a spinal cord compression or just a local compression within the urethra. And as I said, 41% of patients with cord compression may not present with backache. This is again an important subset of patients to be observed. And then we need to have a high degree of suspicion in these patients. In some patients, backache can be the presenting symptom and not necessarily the end of the disease that the patient has a spinal cord compression. So what do we do when a patient comes like this? Apart from all the routine investigations, MRI of the spinal cord with or without contrast is the gold standard. Many of those patients have already had bone scans and PET scans, and Dr. Kallur has already clearly delineated the molecules which are available and which can detect even the smallest of the metastasis. Having said that, MRI spinal is the gold standard. In few patients where MRI is contraindicated, either with pacemakers or any other implants, then a CT myelograph can be done to look for the soft tissue compressing the spinal cord, and additional blood tests as and when required. Other investigations like X-rays and bone scans, as Dr. Kallur said, most of them have been given up, and the diagnosis of choice for diagnosing the metastatic load is a PET CT. But as far as spinal cord is concerned, we definitely need an MRI or a CT myelography to look at the soft tissue component of the disease which is compressing against the root or the cord. Few pictures as shown here. These are very common images for a patient who can sometimes present with these diseases. This again is a disease. This patient presented with a bump on the head, and investigation revealed that he had a PSA levels which are very, very high. And a PET CT did show extensive metastatic disease of prostate cancer, as is seen in this particular disease. I'll just skip for want of time. And this is a classical ivory vertebra, which is a sclerotic metastasis, which is the commonest form of presentation in prostatic cancer. So we have certain scoring systems. Of course, having said that the bone scan is almost obsolete, this scoring system by Solovey can be used to divide the disease into benign disease. I mean, the scale of 1 to 2 can be a mild disease, and scale of 3 to 4 being a maximum metastatic load. And this can be used to whether order an MRI whenever required. What are the goals of treatment in a spinal cord compression? Apart from other organs, which we have already spoken about in prostatic cancer, Cord is special in that we have to maintain osseous continuity, thereby improving mobility, and also relieve cord compression so that the preservation of neurology can happen, and at the same time provide pain relief. Most of these patients, as I said, is already loaded by metastatic disease elsewhere, and it is important to maintain the quality of life, if not improve the quantity of life or improve survival. Indirectly, we can affect improvement in quality of and quantity of survival by making sure that he is independent till the end of his disease. As has been already said, medical management will include hormonal manipulation, steroids, analgesics, bisphosphonates, denosumab. I don't want to go into the details because it has been in detail dealt with earlier. I will just touch upon few of the surgical managements that a neurosurgeon will do whenever called for a patient with prostatic cancer metastasis to the spine. The surgeries can be divided as ablative, augmentative, resective, reconstructive, and some patients we do say that they are relatively inoperable. Ablative surgeries are local surgeries which can, if there is a patient with a single spinal metastasis not responding to radiation or other routine pain relieving measures, we can insert radiofrequency ablation electrode through the pedicle or through percutaneous measures through a guided, image-guided method like a CT scan or an ultrasound into the lesion and pulse radiofrequency pulses so that it produces heat and destruction of the local metastasis, which can lead to significant pain relief. Augmentative procedures are more important, and as I said, in comparison to other metastasis, the patient with prostatic CA having a lytic metastasis and a collapse requiring a vertebroplasty or a kyphoplasty is rarer. Having said that, in those patients who does have lytic metastasis with a fracture, vertebroplasty can be a simple percutaneous procedure which can sometimes be done under local anesthesia in the prone position, and wherein bone cement is injected into the vertebrae, which is causing the symptomatic compression, and either expanded by balloon in terms of kyphoplasty, increasing the height, or just like that, introduce bone cement, which is an exothermic reaction, also kills the cells as well as maintaining the vertebral height as well as the strength, thereby giving rise to immediate pain relief on the table. And these are gratifying procedures when done. Resective surgery is very rarely if there is extradural compression in soft tissue, mostly compressing the cord from the dorsal aspect. We can use a laminectomy as one of the procedures and resect the tumor, thereby relieving pressure on the spinal cord. But this type of surgery is a rarer possibility. I'll just conclude in the next few slides. And reconstructive is a complex spine instrumentation can be done in those selected patients in whom the longevity is expected to be a little more than usual, and then other methods are available to improve the longevity. This is a slide of a percutaneous vertebroplasty. You can see that the very, very small incisions can be done under local anesthesia, and the cement is nicely seen in the lytic metastasis, and it has to be done from both the sides. Here also we see a patient with a fusion already done once for collapse. And this again is a slide of patients who have undergone complex spinal reconstructive surgeries, including corpectomies and complex spine instrumentation in selected few. As I said, additional therapies, I will not go into this. And prognosis, when detected early, even before the onset of paraplegia, most of these patients can regain ambulation and continence, and we can improve the quality of life. So the factors influencing prognosis again has been dealt with extensively earlier. So the final take-home message is when to do an MRI, even absolutely when the patient has back pain or a neurological sign or has a radicular pain, it has to be considered. Sometimes disease-specific factors like if the bone scan shows extensive metastasis or the duration of hormonal therapy is more than 2 years, they have found subclinical occult spinal cord metastasis to be very, very high, and then it has to be considered as a screening mechanism, or the presence of increase in other markers during the follow-up, absolutely. And such patients, whenever there is an improved survival beyond 6 months, adjuvant therapy is already been started, or there is a significant cord compression, patient having a back pain, not responding to routine measures like hormonal manipulation or radiotherapy, such patients definitely we can have local therapies or augmentative therapies to improve their back pain and relieve spinal cord compression. And of course, when an MRI has already been done and showing cord compression, such are the patients which will improve with a decompression on a timely basis. Thank you.
Thank you, Dr. Praveen. Next, we will talk about the fifth vital sign of pain, which is arguably the most important symptom of advanced disease. And I invite Dr. Raghavendra R. He is a fellowship-trained interventional pain specialist with fellowships from North, East, and West corners of the globe, Singapore, UK, US, and now practicing in South India as head pain and palliative care at Sidecare Hospital. So over to you for next 7 minutes.
Thank you, sir. I think it's nice to have a talk after Dr. Praveen. I'm meeting him after Nimans over this podium. He stopped with pain. I'm going to continue with pain itself. I think we are talking about pain management in metastatic cancer. So whenever there is metastasis, definitely it becomes a life-limiting illness. So therefore, there is a role for palliation for sure. Where it has to start? It has to start from the word go. Now, the concepts of palliation are the following on the left. That is, it has to be a competent, continuous care. I'm not mentioning here saying that urologists or other people do not, but we should work as a team to have this continuous and competent assessment by everybody having that same kind of assessment patterns by the entire team. It has to be done at different settings. This is where the bridging happens between the treating person in the hospital or at the different settings. Could be at home, could be at hospice, could be at any other settings, which could be, or a respite center also. Communication, when it fails, everything else fails. I think Dr. Brinda would actually extensively talk about communication. She's an expert next. I think that is where it's important. And the concept of multidisciplinary team was what was all mentioned before. And we have moved on to interdisciplinary team. I'll just come to the end of my slide where I will put across what is interdisciplinary inputs all about. Now, the components of any cancer management is disease management. I think all of the experts are talking about disease management. From there, improving quality and dignity of life. Supportive and symptom control become the next two components of any form of a chronic illness. And we know that prostate cancers are a chronic issues, survival of almost up to 10 years in stage 1, stage 2, and going up to 5 years in stage 3, stage 4 could be probably. So therefore, any chronic dwelling issue should have these both components or all these components running from the day one. Now for pain management, everybody are talking about cancer care from the course of diagnosis, specific cancer treatment, and multimorphic cancer pain management is something which everybody have put across. Now, other things which were actually a little bit left over were concomitant treatments, which could be running because of his cardiac issues, could be other issues, because you could have a geriatric group coming here. Comorbidities could be osteoarthritis of the knee, shoulder issues because of his diabetes, frozen shoulder. It could be other pains which could be actually affecting him. Associated other diseases, he could have any of the other systemic diseases which could be affecting him in his day-to-day activity or quality of life being affected by that. And the social environment or the environment which the patient is actually there. It could be a cultural difference, it could be a social difference, or any of the other. Now, do we have a standard fixed pattern? The WHO ladder, everybody says step 1, 2, 3. Is that enough for the entire management of the pain? I don't think so. Now, what is the new kid on the block? It is to find that it has to be a dynamic, the concept has to be multimodal, as well as it has to be personalized. As everybody are talking about personalized cancer management, I think personalized pain management also makes a lot of difference in the ongoing process when it becomes chronic. Now, what do we mean by dynamic? Now, you can see a water droplet falling, but the water droplet, when it falls, does not have the same shape. It changes shape every time. The same way, the pain could be different. The arising or the patient might just come and complain that he's got pain, but you will have to look into what is the mechanism behind it. Now, it could be a simple issue, which is as simple as a back pain, might not be having a spinal cord compression as Praveen put across, but we should have the suspicion that it could be because of that. Or he could have a facetal joint, that is the small joints in the back, which could get degenerated because he's got metastasis in his spine and he's rotated and he's moving. When he's rotated and moving, not only the facet, the muscle also can actually get affected over here. The simplest of all the pains could be myofascial pains, and most of them are all treated with tramadol, which could not be enough at all. Over here, simple understanding of that concept, putting across what he has to do about the exercises and how to move about, get up, sit, go to his standard patterns of care when daily living has to be made, has to be looked into. Effective and emotional components have to be checked into it. And continuum of this evaluation is very, very important. Now, continuum of evaluation, what I mean is whether it is physical, is there a distress component because of psychological or spiritual has to be looked into, as well as the social economic. And it is a multi-pronged effort over here, and a single concept by a urologist would not be able to be managed, and the team comes to effect over here looking into all these aspects. Once it starts become multimodal, then it cannot be actually a customized. What is the difference between customization and personalization? Customization is you ask certain questions, or you give the questions to the person who's the end user. They will tick the boxes. Like you could have the Netflix, wherein you tick, this is what is my thoughts, and then it would actually fix upon, this is what you should view or see. It's the same thing for pain, is something which was a concept before, but I don't think so it is something which could actually be there, because you have different specialties. I told it could be a pain arising from the bone, from the nerve, tendon, joint, ligament, or from the disease itself. So where it has to be undergone in disease management, the specialists like you, who could be the surgeons, could be the medical oncologist, or could be the radiation person, could be a crux over there to help in the disease management. Whereas in the supportive and the symptom control, when it comes to, we could have the entire gamut of people who could actually be the comprehensive oncological care, who could personalize this to their concepts, because they are the specialized people in moving, getting up, getting down, or rehabilitating them once they have a fracture or something, and getting back to work, getting back to their other things. So occupational therapist works over there, or he's too irritated, he's too anxious about his disease. Communication becomes very important over there. So therefore, it becomes a personalization. Now, this is where we were actually on the concepts of the multidisciplinary team. We are moving on to interdiscipline, wherein we sit, we actually think about and put across what is the best for each other. So therefore, early integration of palliative care is the standard for metastatic prostate cancer. So therefore, when you actually have all the concepts built in, the quality of life is improved. That is where we actually are. I think I've actually taken about 6 minutes, 30 seconds. That's more than enough. The concepts is what is important here, rather than saying that denosumab or a specific drug or a specific management is actually going to be making a matter better for each. So I hope I've actually covered whatever is best possible in this short time. Thank you, sir.
Thank you, sir. Thank you. That was a great talk. Next, I invite Dr. Brinda to speak on end-of-life care. She is a celebrated pioneer and founder director of Center for Psycho-Oncology at HCG. Welcome, ma'am. Next 8 minutes for you. Dr. Brinda? I think there is some problem with
Dr. Brinda?
Okay. Raghunath sir, can you please speak?
I think I was on mute. I'm sorry.
Yes, yes, Dr. Brinda, please go on.
Yeah. Are you able to view my slides?
No, ma'am.
Share your slides, madam.
Okay, I will. Are you able to view now? Are you able to view?
No, ma'am.
No, madam.
Oh. Just give me a second. I'm sorry about this.
Ma'am, you can just click on the share screen button, bottom to the Zoom window.
I've done that.
Yeah.
Yeah, now you're
Yeah,
able to
it's coming right now. Just
Okay.
make it full screen.
Yeah, I'm sorry about the snag.
Yeah, thank you, ma'am. Yeah.
Yeah. So I was at a point where I was saying that so far we were trying to travel our patient through curative and life prolonging kind of care. And when we hit a roadblock, obviously now we have to stop to wonder how we are going to offer deliverance to our patient. And I come only from the mental health perspective, and our job is quite extended because it goes beyond end-of-life care, because we also manage grief and bereavement. I'm only able to give you a bird's eye view considering the time constraints that I have. Therefore, the goalposts in this travel of the cancer journey, as it were, keeps shifting. And I think our focus would be for end-of-life care, it is comfort always. This comfort always can be for few months, few weeks, or even for few days. And in order to be able to arrive at or to be able to offer this kind of comfort, I think it's very important to understand what are the needs of patients and their families. To understand this need, I think it is an eye-opener when we look at volumes of data that I have kind of poured in for prostate cancer to candidly show that patients are challenged by functional difficulties, psychosocial and sexual difficulties across or throughout the cancer journey, as it were. Matters get worse during end-of-life care. Particularly, the last 6 months is reported where they have the worst quality of life, and ask why. It's not only because of advanced disease, but because we are constantly trying life-prolonging treatments, which end up having primarily a lot of side effects, which compromises on their quality of life. Therefore, it has to be a judicious judgment between how are we going to balance all the therapies that come our way versus the quality of life that we are able to offer to our patients. So the cancer journey is not just about milestones, it's about these moments. And these moments come only when we understand the overall picture of quality of life in its totality, not just symptom control or comfort, but good death and dignified parting. So I think that should be the focus of the end of life care work, as it were. But there are several challenges on the mental health domain because patients come with a mixed bag of emotions. And while pain that Dr. Raghavendra and Dr. Praveen were talking about is physical, to a large extent, it is a notable risk for depression and suicide. Depression is, to a large extent can be classified as a psychiatric element, which is like major endogenous depression is what we come across even clinically. And 45%, that is huge number of patients actively ruminate about suicide. So the suicide risk is again fourfolds more in prostatic cancer, and the risk is increased with hormone therapy. And what are these people really crying for? They're crying because their dignity gets compromised, and therefore the desire to live slowly starts to diminish during this phase. All along, they manage, they cope, and good coping is what results in good adjustment. But unfortunately, towards the end, they give up, and this poor coping is what impedes, the medical decisions as well as the treatment outcome. Most importantly, Dr. Praveen mentioned about independence. That is a sense of control which patients equate with good death. And what has been found in this survey from Oregon is very interesting. Patients who requested for physician-assisted suicide were actually complaining that they do not have control, and that indignity is what is prompting them to kind of, terminate their life. So what happens overall? They get into this emotional whirlpool of a whole bunch of issues and concerns that start to kind of, spin around them, which causes existential crisis and brings about death anxiety as well. So where are all these hidden patients and the second patients? Family members are now known to be hidden patients and second patients. They go through exactly what the patients go through, and in fact, even much more. If you look at the center part of this circular bit of the slide very closely, while 90% of patients wanted to die at home, care providers believed that they were not adequately equipped, to deal with that kind of a scenario. That's primarily because they're burnt out and experience distress, which really kind of compromises on their quality of life. And these are people who are absolutely neglected during this journey. So what is the plea of both the patient as well as the family? They want death with dignity. Are we geared to offer them that? Data shows very clearly we have inadequate training in end-of-life care. And very often we shy away from it because we are confronted with our own mortality, and we believe it's a sense of failure when we are not able to restore that life. Having said that, clinically, we do encounter and we are often challenged by this scenario. So how do we equip ourselves? It is important to have these 5 alphabets, in our part of our training. The last alphabet is actually inserted by me. The original model was only the ABCD. While the attitude, behavior, compassion, dialogue is very important, equally important is the empathy to see things from a patient's perspective. That can happen only when we understand the goal of end-of-life care. It's death with dignity and offering them good death with a good plan. And that can happen only when we closely interact with our patients and their families to understand what their needs are. And this can happen when we pop this magic question to them. What do I need to know about you as a person to give you the best care possible? And patients will tell us what needs to be done. Support is not what we give. Support is what the other person wants. And believe me, there is convincing evidence and research that this one question can be a game changer for patients and their families, and we as care providers as well. So therefore, throughout the cancer journey, while we are offering them several cares such as curative as well as prolonging of life, it's equally important to integrate a multidisciplinary care team alongside the supportive care as well. Most important is the psycho-oncology service. And if you look at the arrow very closely, it is starting much before and it ends beyond. So the role of a psycho-oncologist is from womb to tomb and even beyond, because we engage in grief and bereavement. And since because of paucity of time, I'm not really touching upon that particular domain. Why is my slide not moving? Okay. So therefore, this loss, mourning, and grief, which is well within the scope of mental health that we deal with families and their loved ones, I'm unable to cover it because of time, but this is just to drive home the point how important this care for the family who is completely lost in this, transition phase of the cancer journey that we undertake with our patients. Therefore, good palliative care or end-of-life care is all about viewing patient as a person, and this makes a profound impact on their overall well-being. So what are the learnings of today? Prostate cancer, patients and their families, as you saw, have complex functional and psychosocial difficulties. Therefore, initiating interdisciplinary support right from the point of diagnosis is very, very important. And the goal of end-of-life care is symptom management, quality of care, and never to forget, we should offer them good death. And that can happen only when we ask this magic question, what do I do? And, that I can offer the best for you in terms of care. Somewhere in this deliberation, earlier part, the prescription was made in terms of diet, exercise, and so on. I think do not forget to make this prescription, which is mandatory to recommend psycho-oncology from the beginning itself, because our role is from womb to tomb and even beyond. Because life is not a matter of milestones, but also of moments, and these moments come only with emotional well-being and comprehensive cancer care. This is what the patient's family would always remember. So therefore, it is very important that we come up with realistic goals and make sure at least they have good memories of their departed loved ones. Thank you.
Thank you, ma'am. I last heard you in February 2019, and after that I sent my first psycho-oncology referral, and now I regularly send it in RGCI. And our patient feedback performance show improvement. Patients are really happy now. It's a regular feature with us. So before we move on to the experts, Anish sir, any words of wisdom from you?
Yeah, thanks, Jiten. Though we are slightly delayed, but I can't resist stealing a minute or two from the experts with their permission. To the first presenter, regarding the PAE, I would say that prostate artery embolization needs to be done with a great care. It has a lot of complications. The second message to the postgraduates and others is that if patient comes with an obstructive uropathy and he is in the initial stages of, say, metastatic hormone sensitive stuff, then it's not the end of the day. We have a lot of things and drugs, to take him along. We can just let him go through the crisis with stents. This is as opposed to what it was in 30 years ago during my post-graduation days, when we used to say this man is doomed. Similarly to Praveen, I would like to say that, I had two patients during my residency and early phase as a consultant. When I thought the patient has come with spine fracture, he is paraplegic, so he is doomed. But that is not true. Now we know that if he is again at the earlier spectrum of the disease, even though it could be metastatic, but if it is very well taken care, and we need to have a good balance between where to use a radiotherapy versus when to offer surgery. So if we must start actually with radiation, and if the patient still continues to worsen, then offer him immediate surgery. That is what, after so much evidence-based literature and my experience, I have learned that we need not, hurry up and straight away go for surgery as we used to do 25 or 30 years ago. So we need to have a very good cooperation between radiotherapy and surgery. An interesting thing, Praveen, I had a patient who had neurological signs, paraplegia, everything, but the MRI did not show anything, just a bit of evidence of cord compression somewhere. Now, in today's date, I had another patient, but I did PET-CT for him, and I found that it was a soft tissue metastasis, which was actually going through the intervertebral foramina and compressing the epidural space. So that was not possible during my residency days. We were just wondering, the patient has neurological signs, some paraplegia, but there is nothing on MRI. So things have improved a lot to the younger generation. We are much better off. For the radiation, we have radium-223 with alpha emitter. And the oncologist could not tell you about this due to paucity of time, but lutetium and samarium, they were beta emitters, not as good as the alpha emitters. So with that, I would hand over this to Dr. Anand Kumar for his comments, expert comments, please. Thank you.
Anand sir.
Dr. Anand Kumar sir and Dr. Jagdish Kulkarni sir.
Go ahead, Anand. Yes, I've got a couple of comments. Dr. Anand, would you like to go first?
Sir, you have to unmute, sir. You have to unmute.
Yeah, Dr. Jagdish, please go ahead.
Yeah, thank you. Well, most of the things have been said very well and very timely, I must say. A couple of observations which I have is, as pointed by the psycho-oncology group, that they require home care to be included right in the beginning, and psycho-oncology should be coming there. I fully agree with that. 20 years ago, we were talking about terminal homes and home care and hospices. However, what I found recently was patients are not willing to go to these terminal homes. They would like to have at home. And I think that's one thing. The other thing which comes to my mind, especially in metros, where children are abroad, and these are only lonely older men, and sometimes wife is there, or wife is equally debilitated, can't take up that. And they are asking for euthanasia. Mind you, euthanasia. And that is what is bothering us. And they also talk to me that the law has been passed. And doctor, why are you not advising me euthanasia? And as Dr. Brinda rightly said, the dignity of death, because this is, instead of dying daily, I would like to die once. And can you do that for me? And I have really no answer for that. The third point, which is always asked, is what about the non-allopathic groups? Should they be included in this? Say, for instance, Ayurvedic, Unani, they have their own roles to play. And I think this is what the food for thought. But in overall, everything has been excellent, and hats off to the speakers and the, of course, moderator. Thank you very much.
Yeah. Actually, this session was very good, and because this session was the one which is except that Balakashyap one. Most of the things are quite new to the urologists because we are basically not involved in that. And I tell you few things like in our urology training, the great Dr. Bapna used to say, if the patient develop uremia, don't do anything because this is the safest way, the patient will die. And most of the patients take that when you know that there is a multiple metastasis, nothing much you can do, it is happening. But once I suggest that the patient has given written complaint that this doctor is not treating and telling us to die. But the jokes apart, but other thing is that pain management is also very well covered. Actually gave the good concept. And I tell you, because I have seen some of my relative in the terminal stage of cancer, not the prostate cancer and other cancer, and that pain management, people coming at home and giving different kinds of things, even though we know about it, but they were delivered and they were managed, made the patient comfortable. And Dr. Bindra's concept is very good, and at least it should come, and this is a philosophical thing, and slowly and slowly patient relative and patient themselves accept. But and this has to come more and more commonly in the terminal care, but everybody is so scared of this legal problem that they try to avoid it, because you never know when you get trapped into that and who will complain against you. But probably the proper person taking, like, communication is one of the very important thing. How do you communicate? Like even in transplant, that good communicator can make a difference whether organ will be donated or will not be donated. So same way, it is a good communication is very important. Pain management is very important, especially in terminal stage, because we don't manage at that stage. We refer the patient to medical oncologist and patient stays home. And I agree with Dr. Jagdish that in most of the patient also late stage, when they understand, you can make out from the face, they know that nothing more can be done. They also said, doctor, let me go home. And the relative come and ask. Then we tell them whatever he wants to eat, whatever is, just take care of him, make his last few days happy, whatever way you can do it. So that kind of concept is very important in cancer care, and prostate cancer is so common for all the urologists, and it happens in elderly population. So all these points which was covered this session is very, very relevant.
Very well.
And we have taken many points to take care of it. Thank you.
Thank you, sir. We will move on to the next session, which is miscellaneous, where we can't fit these important topics into any of these sessions. So that's why we have categorized these topics under miscellaneous. I thank the previous moderators for the fifth session, Dr. Anish and Dr. Jiten, and experts, Dr. Jagdish Kulkarni and Dr. Anant Kumar sir. I invite now moderators, Dr. T.B. Yuvaraja and Anant Shivaraman, and experts, Dr. Rajiv Sood and Dr. Ramesh sir. Over to you, Dr. Yuvraj and Anant.
Thank you very much, Dr. Raghunath. I think this is the last session, the miscellaneous session. Last but not the least, we've got very important topics coming up. First, we have what is the flare phenomenon, how to administer antagonists. We've got Dr. Ankur Mittal from All India Institute, Rishikesh, to give us this lecture. Go ahead, Dr. Ankur.
Please unmute, sir.
Yes. Thank you, sir. Greetings from Rishikesh. So today we'll be talking about...
Sir, we cannot see your slides. Can you stop sharing and reshare it?
Are they visible now?
No, not yet.
Okay, let me check. Sorry.
You have 6 minutes.
Yes, sir. We will do it.
I request the next speaker to be ready with the presentation, Dr. Anup Kumar.
Are they visible?
No.
No.
Shall we move on to the next?
Yeah, I think we'll go on to the next one. We'll give Ankur his time at the end of the session. The differences between various LHRH agonists and antagonists. Dr. Anup Kumar Gupta, who's head of urology, uro-oncology, robotic surgery, and transplantation at Safdarjung. Over to you, Anup.
Yeah, good evening, everyone. So I will be talking about some practical tips about LRH agonist and antagonist. So I have nothing to disclose. If we talk about a historical timeline, we have the agonist introduced in 1980s and the first antagonist introduced in 2003. And then we are using Degerlix in 2008. And now we have oral relugolix in 2020. So this is very important. We should understand how do they act. Only then we can understand the utilization of these products. The agonists, they hyperstimulate the GnRH receptors first, and therefore we have initial increase in the LH and testosterone production. Now this is very important because this leads to initial flare phenomenon, and also whenever we give injection, there is some microsurges in the testosterone production, which leads to flare. On the other hand, we have antagonists. They act on the receptors, they block it immediately. So there is an immediate suppression, and which is retained for the longer period. Also, the FSH levels, they are depressed in GnRH agonist, but they are not maintained. However, in the antagonist, they are maintained over a long period of time. Very important concept of this cardiovascular toxicity is still debatable, but various studies have shown that antagonists, they do protect this cardiovascular risk, because the agonist, they leads to rupture of this plaque and leads to various consequences. So we do have this thing in our mind when we use these products. Some of the commonly used LHRH agonist, I'm just enumerating here. You can see leuprolide, we have the Lupron or the Eligard one, and the Gosrelin is the Zoladex, and the Tutorelin is the Palmorelin. Out of these, the ready to use is only the Zoladex one. Rest we have to reconstitute. Then the subcutaneously, they can be used, all these three. Palmorelin is the only one which can use intramuscular. The storage condition, if we see, the Eligard is the one which has to be refrigerated at 2 to 8 degrees. All others can be used at a room temperature. We have 1 month and 3 month depot injections. The 6 months are available in Eligard and also in the Decapeptyl. Now shelf life is good, 2 to 3 years, and they have specific syringes which are pre-packed with the injections. Going to antagonist, the Pharmagon is the most commonly used Degerlix, and we are using 240 milligram as a loading dose, and 80 milligram is monthly dose. And now we have this Relugolix is still in the phase 3 trial going on, 360 milligram loading dose and 120 milligram daily dose. Now this Degerlix does not require again a cold storage. This is a good thing, but again it has to be reconstituted and it's also given monthly, and it's a very costly drug. So these are the downfalls of using antagonist. Dose again, we have different doses, like Zoladex is 10.8 for 3 months. Then Eligard comes in 3 monthly is 22.5 and 6 monthly is 45 milligram. Palmorelin is again 11.25 milligram 3 monthly dose. Now coming to some of those important side effects, I just want to highlight the LHRH antagonists. They have more site specific reactions. All the side effects are almost common, so nothing to choose. I just want to focus on this systematic review and meta-analysis, because this was included in latest EAU 2020 guidelines. And we see this meta-review, these are the summaries, that Degerlix definitely leads to the castrate level of testosterone suppression in the initial first month, and it continues for 1 year. And the side effects are site injection reactions, and severe side effects are lesser, but they are not significant. This is again something to be remembered. LUTS, again, higher reduction of the symptoms with Degerlix, and this higher PSA, PFS, but again, the follow-up is only for 1 year. So all this we can say that we can use the antagonist in these patients who have some history of cardiovascular disease, a high volume disease with the impending spinal cord compression, and a patient with LUTS. And this is something about oral Elugolix. This is a very promising drug, phase 3 trials showing again castration level higher in the Relugolix as compared to agonist, and it is sustained over a period of 48 weeks. And even after we stopped it, the recovery is very good. Also, the cardiovascular events, you can see it's very, very less in Relugolix. And they concluded that the rapid sustained suppression of testosterone in this group with 50% reduction in the cardiovascular effects. And what do our guidelines say? They say that antagonist should be used in patients with impending spinal cord compression or a bladder outlet obstruction. But again, this is a very beautiful observation, that they do admit that there is a better PSA, PFS in Degerlix. But again, there is a positive data because we don't have more than 12 months data, and we cannot find out the superiority of one drug over the other. So my take-home message, the practical points of view, that LH agonist versus antagonist, we still don't have a winner. Both have good, similar outcomes. However, agonist, I will say, have a better compliance because of the 3 monthly injections. It's more economical at right now. Antagonists definitely have a sustained suppression of testosterone and also FSH. It does result in some cardiovascular benefits, but again, these are not in the guidelines. I would prefer, and the guidelines prefer, to use this in spinal cord compression and with the high LUTS scores. It does have more tendency for local site reactions, and we are looking forward for this oral relugolix because this will decrease the use of injectable antagonist and will improve the compliance of the patients. So thank you very much for your listening.
Thank you very much, Dr. Anup. That was an excellent talk. And now I'm going to invite Dr. Ganesh Bakshi, who's the head of uro-oncology at Tata Memorial Hospital. And he's going to talk to us about the role of bicalutamide, HORN1, and ketoconazole. Over to you, Dr. Ganesh.
Yeah, thank you. I think, okay, because I was seeing the presentation of Anup, I'm just sharing it right now. So is there any role of bicalutamide, phosphestrol, ketoconazole? I hope you can see it, right?
Yes. Yes.
Going ahead, bicalutamide, it's an old drug, as we all have used it a lot, 1995, and there are so many generations of drugs of the calutamide. So a non-steroidal anti-androgen, potent at the time, and once daily dosing 50 or 150 was thought, and 50 milligram per day was inferior. So bical monotherapy was at 150, as we all know about it. And bicalutamide did maintain a high level of serum testosterone. So there was significantly better quality of life in the domains of sexual interest and physical capacity. But the adverse effects, 60 to 70% with these things, gynecomastia, breast pain, and GI toxicity. And because of these adverse effects, it was not recommended that time for a monotherapy, although it became briefly popular and used in some context with the radiotherapy. So CAB, complete androgen blockade, where bicalutamide was added 50 milligram to ADT, and some individual studies did show a benefit at that time. No RCTs actually, but with flutamide, one RCT showed no survival benefit. Other meta-analysis just showed PFS, that's it. This is in CRPC. So Terrain and Strive, there are two studies in CRPC where enzalutamide and bicalutamide, and both show PFS increased with enzalutamide, support enzalutamide in over bical in MCRPC. So do we use bicalutamide as a part of CAB? It was earlier used plus ADT in CSPC, but not recommended today. However, widely used in resource limited setting, can be used. Days of bicalutamide is damn cheap as compared to the other drugs. All guidelines today recommend combination therapy with many new drugs. And if at all we use bicalutamide, it's for the flare associated with LHRH agonist, or in very few people who don't afford it. Going ahead, this is a radiation role, radiation with or without anti-androgen in recurrent prostate cancer. So addition of 2 years of 150 milligram per day bicalutamide did show survival benefit. Coming to phosphestrol, many have used this drug, also known as, it's a estrogen analog. So estrogen inhibits synthesis of adrenal androgens, increased level of testosterone binding protein, and therefore reduced level of free testosterone. And we have been using this HORN1 120 milligram. The cost comes to around 70 per day. There has been a Indian experience published now with Adyar, and 2012 to 15, 47 patients with MCRPC. And if you see the median OS, 14.7 months, PSA fall of more than 50% was seen in 55% with a favorable safety profile. So that is a good study, not a very bad study. We didn't ever have any documented evidence on that. And can we use, this is just an extension to phosphestrol, can we use estrogens instead of LHRH agonist as such? So on the left is what we standardly use, and this is the transdermal estradiol causing testosterone suppression. And this is one estrogen therapy in patients with prostate cancer, a contemporary systematic review. It did conclude that it is important to investigate alternate route of estrogen administration. And then the Stampede RM, which we all know, it has an outcome measures of OS, PFS, castrate level of testosterone with a control arm, goserelin versus transcutaneous estrogen patches. So phosphosterol today has been used in addition to androgen deprivation in resource limited setting. Again, the RCT is about estrogens. Coming to ketoconazole, the rationale behind its use, again a drug which many of us have used in past. It works on the abiraterone pathway, but instead of two enzymes being inhibited, it comes at CYP17 only, not the 20A. Dose is 400 milligram TDS in the best way. And if you see the studies, they are all from earlier years up to 2014. And the PFS was seen, but I don't think any great OS advantage was seen with ketoconazole. So ketoconazole before docetaxel, if used, greater than 50% PSA decline in 20 to 70% of the 75% of men. Time to PSA progression has been variable, 3 to 14 months in many studies. And ketoconazole after docetaxel, time to PSA progression, if you see, it's 3 months. So why has it fallen out of favor? Thrice a day dosing, 21% have grade 3-4 toxicity. Most common side effects, neuropathy, ototoxicity, 2% grade 3-4 hepatotoxicity, modest benefit with disease progression, no survival benefit. Guidelines, actually, European guidelines, no recommendation. AUA, ketoconazole is not included in standard treatment guideline. Alternative agent in CRPC today, who are unable to accept any other drugs. NCCN is similar to AUA with caveat that ketoconazole should not be used if disease progression is on abiraterone. So ketoconazole is an option in CRPC today if standard therapies cannot be offered. Thanks. Thank you so much. I mean, that's about these 3 drugs.
Dr. Yuvraj?
Yeah, hi. Thank Ganesh. I think Ankur is ready. Ankur, can you share and present? Yeah, we can see now.
Right, sir. So, greetings from Rishikesh. So, we'll be discussing flare phenomena today. So the flare phenomena we'll be discussing regarding CA prostate and in context with LHIH agonist and abiraterone. It is biochemical flare, it can be disease flare, it can be a radiographic flare. So let's discuss about androgen and testosterone flare. So if we see the testosterone after LHIH agonist, it is peak at day 3 and comes baseline day 7, and the castrate range is 3 to 4 weeks. So but what about PSA flare? So as per the literature, review literature, none of the RCTs, they show that with testosterone flare, there is PSA flare. So only there is except one observational study at Sasagawa et al. That minor, there was a minor PSA flare with the testosterone flare. So now, but definitely there is a PSA flare with abiraterone. There is an article in 2016 by Ugeda et al. They said in patients of abiraterone, there is 6 to 10% chances of PSA flare, and patients with PSA flare, they take a longer time to come to another PSA. And this is an important thing, around 12 months. And patient without PSA flare, another comes in around 3 to 7 months. So here the importance of PSA flare comes in patients with abiraterone and should be considered. The condition here we have to discuss is disease flare, which we are more concerned about, like patient with increased bone pain, increased low impact symptoms, spinal cord compression, and cardiovascular complication and death. There are certain RCTs which shows that there is disease flare with the LHIH agonist, but there is transient bony pain, less than 10% incidence, and the more lethal combinations are less than 3%. So exactly, are they really deleterious? So the deleterious complications are very less than 3%. And now here comes, we have studied a saturation model of CA prostate, which comes into picture. Historically, what we think, testosterone level directly proportional to risk and progression of CA prostate. But 2009, the saturation model says the growth of CA prostate is sensitive to changes in serum androgen at very low concentration, that is less than 250 milligram per DL. And above a certain level, increase in serum T causes little or no additional androgenic stimulation on CA prostate. And this is an important point to be considered here in flare phenomena. So this model suggests that patients with very low testosterone, that is less than 250, and extensive vertebral metastasis or impending spinal cord compression may be on highest risk of disease flare. So this is these small subgroup of patients where we are considered about disease flare with LHRH agonist. And in these patients, if we have a testosterone level prior, that gives a clue to us that if it is less than 250, these patients probably can have a disease flare or else not. So this is extensive vertebral metastasis patient, impending spinal cord compression, severe LUTs, and high cardiovascular risk group, patients can have disease flare. So if a patient is having flare, definitely in this subgroup high-risk patients, it's always better to have bilateral orchidectomy and LHRH antagonists. They are preferable as the castrate level of testosterone reaches shortly within 12 to 24 hours or 3 days. But yes, if we are going ahead with LHRH agonist, we have to add anti-androgens, which takes 3 weeks time to come to castrate level. And these anti-androgens, 1 week prior and 3 weeks after therapy is recommended. We can use both bicalutamide 50 mg OD, which is preferable, and also the same results are also shown with cyproterone acetate 100 mg TID. So here, that's why this important concept that disease flare, there is testosterone flare, PSA flare doesn't exist, but cases with abiraterone, we have seen it, yes. And now, how if we are giving LH and antagonist, what is the safe principle to administer it? We are worried about side effects, but if we administer properly, side effects will be less. Induction dose, as we all know, it is 240 milligram, maintenance is 80 milligram, the kit is available. All 4 quadrants of abdomen, we can give the therapy. We should ensure it should not be a pressure site. We should ensure that, yes, after proper cleaning, we have to grasp the site, lift it up, elevate it, subcutaneous tissue, insert the needle deeply, but obliquely, not less than 45 degrees, and a slow, deep subcutaneous injection over 30 seconds to be given. Yes, if there is a blood in the needle, that has to be discarded, and yes, we have to repeat the therapy. So what precautions to be taken during injection of LHRH antagonist to reduce the side effects, local side effects like allergic reactions? Aseptic precautions, reconstituted drug must be administered within 1 hour after addition of sterile water. And we have to keep the vials vertical all the time, not to shake the vials, and to follow aseptic precautions. So with this, I would like to conclude my talk that this unseen area of flare phenomena to be kept in mind. It is not everything to do with LHRH agonist. There is a small subset of patient to be identified. PSA flare with abiraterone to be considered. Sometimes patient with abiraterone, PSA flare is there and we change the therapy and they do well. If we continue with abiraterone, patients are asymptomatic. And definitely when to use LHRH antagonist and bilateral orchidectomy in these high-risk patients are important. Thank you.
Thank you, Ankur. I think we move on to the next topic. Next talk is by Dr. Jay Chakrabarty from Guwahati. He'll be talking on how to manage gynecomastia heart flushes after hormonal treatment. Jay Chakrabarty, please.
Yeah. Yeah. Am I audible, sir?
Yeah, audible, and the screen can be seen. Yeah, you just make it the full view.
Yeah. Thanks.
Please click the arrows on the bottom left.
Yeah, it's not working.
You go to the view and also you can make a full view.
Yeah, sorry. Yeah. EDT in metastatic cancer prostate. I'm talking about the management of first flushes and gynecomastia. These are the 2 most disturbing aspects of EDT. And sorry, it's having problem again. Yeah. Now, causes of gynecomastia. As we know, it's a ADT monotherapy. It's regarding the molecule responsible, bicalutamide has the highest incidence, 85%, versus enzalutamide it's 50%, apalutamide is 0%, and CAB, that means combined androgen bucket, is 13-22%. And regarding the pathogenesis, we know it's the imbalance between the luteinizing hormone, testosterone, and the testosterone converted to estrogen, peripheral aromatization, and gynecomastia, and there is breast pain. And gynecomastia is not so a big problem with other ADT. Now, management of gynecomastia, the prophylaxis is important. Now, prophylactic radiotherapy, single fraction 10 to 15 gray or in 2 fractions of 6 gray. Tamoxifen is another off-label use, that is 20 milligram per day we can give, but the side effects matters. Dizziness, hot flashes, and these hot flashes can be additive to ADT hot flashes, thromboembolic events, and no beneficial effect once stopped. So it's to be continued throughout ADT. Anastrozole is theoretical benefit, the greater benefit with tamoxifen in the context of prophylaxis than radiotherapy, 8% versus 34% effect. And management of gynecomastia, when it comes to once gynecomastia develops, then tamoxifen is superior to radiotherapy. 9% still have gynecomastia after 6 to 9 months of 20 milligram tamoxifen compared to 54% after radiotherapy. Tamoxifen side effects are more than radiotherapy, but ultimately there is no significant difference in quality of life. And surgery in long-standing, non-responsive to medical treatment, already fibrotic changes sets in, then surgery is advisable. Now, causes of hot flushes, loss of negative feedback in hypothalamic noradrenaline production, and then hypothalamic thermoregulatory center is deranged, leading to vasomotor flushing. 44 to 80% men on ADT appears 3 months after starting ADT. Case long term. Reddening of the skin, sweating, palpitations, everything can happen, and more with LHRH agonists than anti-androgens, as my previous speakers already told. Management of hot flushes. Now, general measures, this is often omitted in management of hot flushes. Environment and diet, room, cool, light clothing, natural fibers, lukewarm shower, towel on the bed, is to calm under pressure, and cooling pads. Cut coffee, tea, sip cold, try alcohol in moderation. And regarding treatment, hormonal and non-hormonal. Then hormonal treatment, methotrexate acetate 20 milligram per day is the first line management and standard, and we have to review the outcome after 10 weeks. Sapropterin acetate 100 milligram per day we can use, but as it's hormonal agent, it should not be used as it interfere with ADT. Used when MPA doesn't work. And diethylstilbestrol 0.1 milligram per day, that should not be used. High cardiovascular mortality. Non-hormonal management, there are many agents such as SSRIs, venlafaxine, sertraline, prazometin, and fluoxamine of off-level medicines. Gabapentin, acupuncture has got some effect in addition to cognitive behavioral therapy and soy protein. So all these things are off-level, and we can use when necessary if medical treatment doesn't suffice. Thanks.
Thank you, Dr. Jai Chakraborty. I think it was very crisp and short. I think with this, I invite the expert comments, Dr. Rajiv Sood and Dr. Ramesh, one after the other. Dr. Sood, unmute. Yes, sir.
Okay. Thank you, Dr. Yuvraj. This was a wonderful session. Actually, all the miscellaneous topics, if we directly, indirectly, are related to metastatic CA prostate management, and very, very relevant to our clinical practice, because we get more of metastatic patients in our practice. Now, the flare phenomena, which was the first talk in that, the important is we are talking about PSA, we are talking about disease progression and imaging. But one thing is there, that testosterone decay and fluctuations, these two are important, and that is what we did some study initially almost 15 years back, and we compared different agonists, and it was found that at that time Pomerlin was not there in that comparison, and Joladax or this Goserlin showed that the testosterone decay was faster, and there was no class effect amongst agonists. They were different in use and effect. But one thing is important, that testosterone decay is fastest with the antagonist, and that too, there are no microsurgeries even. So this is important that we all understand that and accordingly take the decisions. But when we give it and we use the antagonists, when we talk about antagonists, at that time, bilateral orchidectomy increase FSH. Surgical, agonists, they keep the FSH at level, and antagonists, they decrease FSH. Now this is not done, very robust studies have not been done for FSH effect on CVS, but now relugolix, which Dr. Anup has mentioned, that has also shown that cardiovascular complications are less, and therefore it gives us more support to the to believe FSH theory. And now coming to bicalutamide, or adding in the initial phase to prevent the initial flare phenomena, or the disease flare, like spinal cord compressions. I have seen patients going for paraplegia or cord compression and in great difficulty. And bicalutamide initially is added. It is useful even today, as was already discussed. And in the initial studies, this was proven that the patients who have osteoporosis, or the patients where because of ADT, the bone health is going down, this may help, and certain studies have been done and published for again calcium is again deposited back in the bones. Phosphostrol is very interesting molecule, and it is not only the estrogen, but it is phosphostrol. It is also the oncolytic, like chemotherapy. So it is something in between the hormones and the chemotherapy. And if we give IV, so I want to add, everything has been said, but I want to add only one thing. If we give IV, it goes straight to the metastasis and gets deposited there. And as it is deposited in the metastasis and in the primary tumor, it is effective, very effective oncolytic action is also there. And recently we are finding the reports, initially cardiac and liver toxicities which were reported, they were actually not from the large series. And one report was published that they are not that much which was anticipated. So phosphostrol in India and in the condition where a metastatic CRPC, or where the patient cannot afford, is very important molecule. And estrogens. Now I'll in the COVID era, there are trials which have proven that estrogens, progesterones, and lowering testosterone, all the three have helped to save from COVID, and also the aggressiveness of the virulence of the virus is also less. So these, in this miscellaneous topics, I think the major things have been covered, and I'm very happy for the whole day's deliberations. And I hand over to Dr. D. Ramesh to add more comments.
Thanks, Dr. Raghu, for having me over. Just want to reiterate what all the speakers have told. The first three talks are almost interlinked to each other. The talk by Ankur Mittal on the flare phenomenon, followed by Dr. Anup and Dr. Ganesh. The conclusion of all the three talks put together is that flare does occur if you use agonist, and there are specific indications where you use a drug to counter the flare where you anticipate it. And Dr. Anup brilliantly told us all the details about the various agents that are used. All of us would look forward to the oral preparation, which is awaited to be marketed in India. And Dr. Bakshi also clearly told that bicalutamide is used to, it's hardly ever used now, especially it can be used only when there's a resource crunch and one cannot afford enzalutamide, then you can use them in metastatic CRPC. Otherwise, other than flare, there is hardly any role. The older generation urologists have a larger experience with phosphosterol. Currently, the younger urologist, and none of the guidelines do mention about it in its use. And there is the theoretical evidence that it does have a cytotoxic effect also. It's interesting to see that Adair Cancer has put out a publication on that. Only time will tell whether it's still going to be used with the newer agents that's been discussed earlier part of the session, whether it's going to be useful in future or not. Hot flushes and gynecomastia, we do encounter it not very frequently though. Gynecomastia doesn't seem to be too much of a problem for our patients in practice, but hot flushes can be very discomforting for the patients. And Dr. Chakravarti did elaborate the management protocols that are used in that. I think we're running well beyond the time. I think I'll take this opportunity to thank Dr. Raghu for a wonderfully conducted session, and it's been most useful. And I personally gained a lot from the previous session where, like Anant Kumar said, that urologists don't have that perspective about radiation and counseling of a family. I mean, that was a very interesting session. I thank the chairpersons also for having us over.
Thank you, Dr. Yuvraj, Dr. Anant, Dr. Raju Sood sir, and Dr. Ramesh sir for giving your valuable inputs. With this, we have come to the end of this session. Take-home messages to come with you and your dinner. It's already, we are running behind schedule by 30 minutes. So all the speakers have given excellent take-home messages. I don't want to repeat that. I thank all the speakers, moderators, experts for your time, effort, and support. Especially, I thank all the speakers for managing the time diligently. I thank USI, ISU, particularly Dr. Raju TP for the support. With this, I would end my message. I over to Dr. Raju TP for concluding remarks. Thank you.
Thank you, Dr. Raghu. It was really a very good webinar. I would like to say a very thoughtfully chalked out program. Truly an A to Z in metastatic prostate cancer. This program has touched upon all aspects of metastatic CAP, but there has been some difference from the usual programs on cancer prostate, that apart from the usual management of the disease part, this time we had touched upon the palliative care to end of life care, which is said it's a holistic approach to the care management of an advanced metastatic cancer prostate patient. And all speakers have done an excellent job, excellent presentations, which were par excellence. Moderators did a very good job. Experts did very well to chip in with crucial and salient views on important issues. I thank on behalf of USI and Indian School of Urology, Dr. S.K. Raghunath, the convener, for laying out an excellent program, which was really different from the usual ones on CAP. Good coverage of an important topic. I thank on behalf of USI and ISU all the speakers for doing an excellent job. The moderators did a good job in controlling the sessions, and they well moderated each sessions very well. The experts did a wonderful job, and we were very much really benefited from their expert viewpoints. I, on behalf of the USI and ISU, thank the Sun Pharma team for all the logistic supports which they have rendered to USI. I further thank the central office, Mr. Navneet Arora and Kiran Arora, for all the supports they have been entering to for the success of this program from behind the screen. Thank you all once again on behalf of USI ISU. Good night.
Thank you. Thank you. Thank you to everybody.
Good night. Thank you. Good night. Thank you. Thank you. Good night.
Good night.
Thank you, everybody. Thank you.